Today, I'm excited to talk to you about the Hernia U platform and what it entails. 4 years ago, we came to the realization that it was time to expand the hernia educational landscape. Dr. Salvador Morales, Dr. Eduardo Pardavila, and Dr. Flavio Malcher then created with us the Fundamentals course. We wanted to offer something to everyone who wanted to revisit their hernia education. This covers the basics of hernia repair to include applied abdominal wall anatomy, techniques in inguinal hernia repair, avoiding intraoperative and postoperative complications, and much more. This course opens again on April 1st. You simply need to go to the course page and enter session 1. You'll be able to take all the applicable material at your own pace from the convenience of your home or office. We then offer a quiz and we'll have a live question and answer chats with all 3 faculty throughout the course. After you've completed the session, the quiz and live question and answer, you will also receive a certificate online with the amount of hours completed. We also offer 2 live broadcasts associated with this course, one dedicated to inguinal and one dedicated to ventral. 2 years ago, we decided to start offering this course in both English and Spanish. Last year, expanding the course with Chinese, French, and Arabic subtitles available to make the material easier to access for surgeons around the world. For the surgeons out there who've already taken this course or those that are simply looking for something a little more advanced, we have another course, Hernia A to Z Advanced. Last year, we opened it with Spanish subtitles. Once again, a course with several sessions, 5 to be exact, each with a forum where surgeons can ask questions and interact with the faculty. This course also offers 2 live surgery broadcasts. Speaking of live broadcasts, let's look at our live program. We now offer monthly live broadcasts, 2 cases from 2 global leaders in 2 different locations around the world. We do this from around the world to give our surgeons opportunity to learn from the experts on their techniques. Whether it be an ETEP with Jorge Diaz, sandwich technique from Ferdinand Koechlering, or robotic IPOM from Dr. Pardavila, they get to be in their OR, observing and asking questions throughout with our moderator and chat box. Good news, if they've missed a case, we have our past broadcasts in our video library that they can go back and check them out. I'd like to talk to you about another fun program you can find on Hernia U, our podcasting page. We actually have a Hernia U podcasting page on an Apple station. You can listen to our global hernia leaders from around the world speaking on what sparks joy in their lives, why they do what they do. Next, I would like to tell you about a new program, our case discussion program. Every quarter, 3 societies will be selected to participate in our case discussion program. Each society will host their own local case discussion program, collect videos from surgeons in their country, and select the top video to submit to Hernia U. All of this will be based off the same criteria, and each winning video from each society will go into our video library as their award. Another new program is our live meetings program. This is another program where we're teaming up with societies. We'll be giving them the platform to live broadcast on Hernia U the pertinent topics that are being presented at their annual meetings. You can watch these sessions for free and learn from top minds in the hernia space. During this time of social distancing, we are ramping up on our offerings and also launching the Master Series program, another new program where our global KOLs present on hot topics live and answer questions from the audience in our interactive chat box. This is just the beginning. We are committed to bringing you the best education from the best faculty in the best and most innovative formats, all through Hernia U. Hello, my name is Jen Petrie, and I am one of the founders as well as the manager of the Hernia U platform. Today, I'm excited to talk to you about the Hernia U platform and what it entails. 4 years ago, we came to the realization that it was time to expand the hernia educational landscape. Dr. Salvador Morales, Dr. Eduardo Pardavila, and Dr. Flavio Malcher then created with us the Fundamentals course. We wanted to offer something to everyone who wanted to revisit their hernia education. This covers the basics of hernia repair to include applied abdominal wall anatomy, techniques in inguinal hernia repair, avoiding intraoperative and postoperative complications, and much more. This course opens again on April 1st. You simply need to go to the course page and enter session 1. You'll be able to take all the applicable material at your own pace from the convenience of your home or office. We then offer a quiz and we'll have a live question and answer chats with all 3 faculty throughout the course. After you've completed the session, the quiz and live question and answer, you will also receive a certificate online with the amount of hours completed. We also offer 2 live broadcasts associated with this course, one dedicated to inguinal and one dedicated to ventral. 2 years ago, we decided to start offering this course in both English and Spanish. Last year, expanding the course with Chinese, French, and Arabic subtitles available to make the material easier to access for surgeons around the world. For the surgeons out there who've already taken this course or those that are simply looking for something a little more advanced, we have another course, Hernia A to Z Advanced. Last year, we opened it with Spanish subtitles. Once again, a course with several sessions, 5 to be exact, each with a forum where surgeons can ask questions and interact with the faculty. This course also offers 2 live surgery broadcasts. Speaking of live broadcasts, let's look at our live program. We now offer monthly live broadcasts, 2 cases from 2 global leaders in 2 different locations around the world. We do this from around the world to give our surgeons opportunity to learn from the experts on their techniques. Whether it be an ETEP with Jorge Diaz, sandwich technique from Ferdinand Koechlering, or robotic IPOM from Dr. Pardavila, they get to be in their OR, observing and asking questions throughout with our moderator and chat box. Good news, if they've missed a case, we have our past broadcasts in our video library that they can go back and check them out. I'd like to talk to you about another fun program you can find on Hernia U, our podcasting page. We actually have a Hernia U podcasting page on an Apple station. You can listen to our global hernia leaders from around the world speaking on what sparks joy in their lives, why they do what they do. Next, I would like to tell you about a new program, our case discussion program. Every quarter, 3 societies will be selected to participate in our case discussion program. Each society will host their own local case discussion program, collect videos from surgeons in their country, and select the top video to submit to Hernia U. All of this will be based off the same criteria, and each winning video from each society will go into our video library as their award. Another new program is our live meetings program. This is another program where we're teaming up with societies. We'll be giving them the platform to live broadcast on Hernia U the pertinent topics that are being presented at their annual meetings. You can watch these sessions for free and learn from top minds in the hernia space. During this time of social distancing, we are ramping up on our offerings and also launching the Master Series program, another new program where our global KOLs present on hot topics live and answer questions from the audience in our interactive chat box. This is just the beginning. We are committed to bringing you the best education from the best faculty in the best and most innovative formats, all through Hernia U.
Congress. We're going to cover now an update in inguinal hernia repair. What is the pros and cons in 2020? We have a great speaker from around the world, from Germany, and it's a pleasure to be with you. And of course, it's always a pleasure to co-moderate this session with my friend Giampiero Campanelli. So it's a great opportunity to discuss about what's going on in the world regarding hernia surgery. You know, we have the impact of two things. We've been doing open surgery and we've been doing laparoscopy. The new guidelines says the laparoscopy is a way to go, and we will discuss that with Ralph and with Manuel, and also the impact of robotic surgery in inguinal hernia is very important nowadays. So I think we have a lot to discuss, and it will be a very interesting session. So Gianpiero, if you want to say some words.
Thank you, Salvador. It's a very great pleasure to be invited and to stay here with all of you. And the first reason is that the knowledge that our family, our hernia family, we are all alive. And this is very, very important. In my knowledge, only one of us is passed away, is Gerson Greenburg, that we have announced on Hernia Journal. So this is my happiness in this moment to see everybody and to hear everybody, to know that everybody is with us. And I don't think that I have to add something else, because Salva was very complete. It's a very important session. I believe that we can start giving the first talk to our friends, Ralph Lawrence, if you agree, Salvador.
Yeah, we have the chat box open, so we will go through all the 5 presentation, and at the end we will go with the question and remarks, and we will be collecting the question and to start the discussion when we finish. So we will go for the first speaker, Ralph Lauren from Germany, to talk about open anterior approach with and without mesh, pros and cons in 2020. So Ralph, thank you.
Thank you very much for this kind introduction. Congratulations to this amazing Congress, dear Salva and dear Manuel. Thank you also for inviting me, for coming up with this controversial topic. And for sure, I love this topic, mesh and non-mesh repairs, for many years. Because of the virtual possibilities we have right now, the unique chance, without having any conflicts of interest, to go into a theater. And for that reason, I would like to invite you to come with me into an opera house, with getting, of course, a new insight might be on this topic. I have no conflicts of interest, because next year the Congress will take place in Copenhagen. I will introduce you, of course, Shakespeare and the Prince of Denmark, Hamlet. To be or not to be, that's the question. And if you translate it for hernia surgeons, of course, you have, of course,
Doctor, we need you to share your presentation, share your screen.
No, we don't see your presentation.
You can't see my presentation, but I have done it.
We thought it was an introduction. Go ahead.
Okay, sorry for this. Okay, that's my presentation. Okay.
Now.
That's right now? Okay, yeah. Sorry for this.
Yep.
Okay. Sorry, so I have to start again. Sorry for this. Hopefully I have not enough time. Of course, the introduction, of course, was clear. Financial disclosures, I have nothing to disclose. And of course, to be or not to be, that's the question. And for translating to hernia surgeons, of course, with mesh or without mesh, that's the question. So since we know the hernia surge guidelines, of course, we know that the transmission seems to be a bit slow, that we have, of course, the answer that the mesh repair seems to be superior for all inguinal hernias. And for that reason, of course, I want to share the screen right now. Of course, the mesh-based repair seems to be recommended for all the hernias. Only in that cases where the patient refuses a mesh, we have the chance to make a pure tissue repair. Do we have new evidence? And the major topics of the groin hernia repair is, of course, recurrences and finally, the pain. And do we have a new evidence in this case, which is definitely not new? Okay, sorry for this. From the Danish hernia database and from the German hernia database, we know that, of course, the risk for recurrences is almost only on 50% of the hernia. So right now, I don't move any slide. So we have also a second observation in the German hernia database. We know that almost 10% of the recurrences are, of course, we have 10% recurrences after hernia repair. But among these 10%, we have almost 45% of recurrences after any mesh repair. And that's something which is, of course, it looks like the mesh not even in every point is superior. What is new? We know something which is new from the database, also from Germany, that the risk for a chronic postoperative inguinal pain syndrome is almost the smaller inguinal hernias as a risk factors. We have this year an update of the Cochrane library, and the Cochrane database has published in 2018 something which is, of course, a different wording in my mind. We have right now the situation in the conclusion is summarized: mesh and non-mesh repairs seems to be effective surgical approaches in treating hernias. For sure, we have the situation that the mesh repairs reduces the rate of recurrence, and as something which is definitely also new, that non-mesh repairs has been favored in low-income countries due to lower costs and reduced availability. The shoulder seems to be not even that bad. So we could get, of course, observational or independent observational study from a health insurance company in Canada, where the hospital cases were summarized for the rate of recurrences, the so-called Urbach study. And with 230,000 patients, they could identify low volume hospitals, mid volume hernia hospitals, high volume, and the Schulweis hospital, and which has the definitely lowest recurrence rate. And the lowest recurrence rate is, I think, definitely significant. And this technique has almost in the expert hands only a risk of 1.5% of recurrences. In the German hernia database, we could identify also two publications which come up in the last 2 years. That was firstly, of course, about the selected group of patients all over. We could identify the same outcome comparable to Liechtenstein, TAP, and TAP. And for the female patients, we could identify when you clearly exclude any femoral openings, then you have the same outcome, the same results comparing to the TAP and TAP repair. Finally, of course, we have a new technique on the market for pure tissue, which is the Desada repair. And the Desada repair is something which seems to be more easy to learn and fast reproducibility. and it has a quick post-operative recovery. And it looks like that there is some fresh wind on the market. Secondly, we have, of course, the publication from Ben David and his group about, of course, the possibility to develop these mesh-related pains, the so-called SIN syndrome. And finally, of course, we know, since their scientific research, something about shrinking, migration, degradation of meshes. I can summarize the arguments in pros and cons, and the pros for the mesh repair are very clear. I have to be a bit slower with the presentation because it's not coming up with the screen. We have the guidelines, we have the less recurrences in most of the studies. It's easy to use. We have a quick recovery. And for the against meshes, we have, of course, the argument we're using a foreign body. We have remaining recurrences also with meshes. We have, might be the mesh-related chronic pain, migration, erosion to organs. Do we have more arguments? We have. And of course, in the last couple of years, of course, we are talking about media campaigns and documentaries which are related to so-called mesh victims. And of course, all the attorneys are just waiting on the front door for any hernia mesh complication in the last couple of years. Something which is definitely new seems to be allergies. Allergies, such an auto-inflammatory response, seems to be something which is published in 2018, which could be a reason to develop any, of course, symptoms which are not even detectable. And if you explant the foreign body after that, it could be an amelioration of the symptoms. And finally, and last but not least, one of the strongest arguments is what are the secrets for surgeons. If you ask surgeons, and we have done it during different conferences, what would you choose if you had a hernia by yourself? And we used a TED voting for this. Then we came to the conclusion that up to 25% of the surgeons would choose for their own hernia a shoulder repair. What is the secret behind? I want to know it. Might be that you know it. This week I had a patient as well, and he don't want to have a mesh. Might be that's something which is, of course, controversial. We know what we are, but not what we are may be. And for that reason, of course, we have some open questions. We don't know exactly the real genesis of the recurrences, the cause of mesh-related pain, and what are the long-lasting mesh effects and biomechanics. And what is, of course, the secret, of course, of having a mesh for more than 30 years in the human. And finally, of course, allow me this question, why companies constantly develop new meshes? It looks like that the ideal mesh seems to be not invented yet. The answer is very simple. Look at the picture, and of course, the answer could be only tailoring. And the tailoring does include, for sure, a differentiation into different sizes and hernia types, the different risk profiles, and the different exertions. And if you look into the details, of course, you can summarize a tailoring with pure tissue repairs for younger patients with small hernias, and a mesh repair for older patients with large hernias and weak tissue. There is also a possibility to navigate, and that's nothing which is definitely new. Since 2003, we have this kind of head score, and this head score gives might be a navigation on this issue. I come up with my final slide, and the final slide is not yet on the screen. With and without mesh is not a question. It's only a matter of differentiation and finally of education. Thank you very much.
Very well, Ralph. Thank you very much. And Salva, do you think that we can go to the next speaker?
Yes.
So,
You have to stop sharing the screen, Ralph. Perfect.
Yeah.
So you can present the next speaker, Giampiero.
it's my great pleasure to introduce Manuel Lopez-Cano, that is the co-congress chairman with Salvador and one of my best friends, and I like a lot all his talk. So I am very, very happy to can hear you on the preperitoneal approach, open approach. That is one approach that I consider very important because the real learning curve for the laparoscopy is the open preperitoneal approach. So please, Manuel.
Okay, thank you, Giampiero, and thank you for your words, and thank you, Salva, again, also for the organization of this meeting that till now is, I think, is a success. Let me to share my screen. Can you see my screen?
No.
Not yet.
Not yet.
And now?
Yes.
Okay, thank you. Now it's good?
Yeah.
Perfect.
Okay, thank you. Yes, my talk will be about preperitoneal mesh repair. Here are my disclosures. I would like to start my presentation, comment something about in my opinion, the open preperitoneal mesh repair landscape. To me, the landscape of this type of approach is a mess. And this mess produces, in my opinion, confusing ideas about the approach. And these confusing ideas make most surgeons cast aside this kind of repair when they are facing an inguinal hernia repair. And why a mess? Because as far as I know, 11 different types of open preperitoneal approaches have been described. But second, among these 11 different types, some of them are using a maximal exposure of the preperitoneal space, and others are using a minimal exposure of the preperitoneal space. To increase the confusion, some of these maximal and minimal exposure of the preperitoneal space, they are using a posterior approach without entering the inguinal canal anteriorly to access the preperitoneal space, and others are using an anterior dissection opening the inguinal canal to access the preperitoneal space. Why confusing ideas? If we look at the literature, some reviews, just an example here in the slide, this work about the state of the art of open mesh-based inguinal hernia repairs. The authors wrote that the open preperitoneal mesh are connected with limitations of visualization, dissection of both inguinal compartments, limitations of mesh positioning, difficulty in teaching, and poorly visualized technique, the so-called tactile technique. However, maybe this is true if we are thinking about techniques with a minimal exposure of the preperitoneal space, but in my opinion, it's not true if we are thinking about techniques with a maximal exposure of the preperitoneal space. So these confusing ideas prevent widespread dissemination and adoption of a standardized open preperitoneal repair. What is an open preperitoneal approach? So, if we look at the literature again, I would like to show you this very interesting and excellent paper I recommend you, written by Raymond Reed 15 years ago. he concluded that the term preperitoneal should only be used to characterize an approach to the groin if it provides enough exposure of the bogrous space beneath the inferior epigastric vessels. Of course, using a posterior approach without entering the inguinal canal anteriorly. So what am I going to talk about then? I am going to talk about a unilateral approach, sometimes can be done bilateral, under general anesthesia, using a posterior approach without entering the inguinal canal anteriorly, with a complete exposure of the preperitoneal space, and using a big MEX 15 by 15 centimeters. This is a short video of our technique. We start the technique with the skin incision, as you can see in the picture on the left. We open all the layers in the abdominal wall, accessing the preperitoneal space, identifying the epigastric vessels and the hernia, and we reduce, as you can see in the video, the hernia using traction and contraction and the help of the body. And sometimes we use external pressure maneuvers in order to reduce the hernia sac, as you can see in the video. We complete the dissection of the sac in a way quite similar, of course, it's an open approach, but quite similar to a laparoscopic approach, dissecting all the sac from the posterior aspect of the inguinal area, and we completely dissect the sac, as you can see, and after we abandon the sac in the preperitoneal space. After that, we look at the femoral canal for a femoral hernia, and we can see here the Cooper's ligament, the hernia orifice, here the femoral vessels, here the epigastric vessels ligated in this case, and here the round ligament ligated in this case. After this, we place a stitch in the Cooper in order to fix the mesh. We split the mesh in order to reach a cone shape, mimicking the cone shape of the inguinal area at this level. We after fix with the stitch the mesh into the Cooper's ligament, as you can see here in the video, and after we deploy and extend the mesh, covering all the preperitoneal space, the medial aspect of the preperitoneal space, at the lateral aspect of the preperitoneal space, as you can see in this video. After that, we review, of course, the hemostasis and so on, and we close layer by layer using absorbable sutures. This technique can be done also, of course, in male patients. On the preperitoneal, in this case of male patients, as you can see here the cord elements, the epigastric vessels, femoral vessels in the bottom, here the Cooper's ligament and the hernia defect. And here the mesh placed covering all the myopectineal orifice, a regular mesh of polypropylene, here the epigastric vessels and the cord elements. We can use this technique also for giant inguinal hernias, as you can see in the picture and in the video. This is the hernia sac dissected, and we resect finally this sac, place the mesh into the preperitoneal space, and complete the operation like in the previous patients. We have experience in the elective setting with this technique. This work was published some years ago with our experience with 1,100 patients with a follow-up about 2 years, with a very low level of wound complications, very low level of recurrences, very low level, in our opinion, of chronic pain. This chronic pain was not an invalidating chronic pain, was something similar, discomfort in the inguinal area. We had also the opportunity to review our experience in the emergency setting, comparing anterior approach with preperitoneal approach, 200 patients versus 100 patients, with a follow-up of 55 minutes. No differences regarding general complications of mortality or chronic pain, but finally we found differences regarding recurrences, with lower level of recurrences after preperitoneal approach than anterior approach. So why this technique? Because we can use in any type of inguinal hernia, in male or female, in elective and emergencies. We are able to cover the whole myopectineal orifice with the mesh. We don't have limits in visualization, only dissection of the posterior compartment, using a big mesh, of course. For us, it's very easy to teach. And we are using, in our opinion, a physiological repair because we take advantage of the intraperitoneal pressures fixing the mesh over the abdominal wall with low level of complications and feasible in ambulatory surgery. Of course, we have relative contraindications in cases of pelvic irradiation, previous preperitoneal dissection, or, of course, hernia recurrences from previous preperitoneal repair with MES. And this is my last slide, and I show you these, again, interesting sentences from Raymond Reed 15 years ago. They are sentences, and in my opinion, very clear message. And he wrote that in the new age of laparoscopic and prosthetic repair, they reinforce the concept that the proper anatomic location of groin herniorrhaphy may yet be the preperitoneal space of growth. Thank you very much.
Thank you very much, Manuel. Thank you for this nice overview, and it will be very interesting to discuss later. And now we have, from Madrid, we have our friend Pilar Hernandez Granado. She's the chairman of the Spanish chapter of abdominal wall surgery.
Not anymore.
And she's a real expert in abdominal wall and also in laparoscopic approach. And she will give an overview of laparoscopic approach, pros and cons in 2020. Thank you, Pilar, for being with us.
Thank you, Salva. Let me share my screen. Can you see my screen?
Perfect. Yes.
Yes. Thank you to Dr. Morales and Dr. Lopez Cano for this amazing idea. I think it's a very great Congress. It's a privilege for me to participate in this extraordinary event. Laparoscopic use in inguinal hernia repair varies from 0 in low-income countries to 64% in some places in Europe. Since the description on the early 19th, the advantages of laparoscopic surgery are well known: smaller incision, less postoperative pain, less wound infection rate, faster postoperative recovery, and less chronic pain. In 2018, the international guidelines were published, and the recommendation was that in male with unilateral inguinal hernia, laparoscopic approach should be the choice, provided that an expert surgeon and enough resources are available. This recommendation supposed a revolution in the world of hernia surgery, where most surgeons perform Liechtenstein repair with very good results, and they ask why they should change their practice. The answer is the anatomy. This approach allows to access to the preperitoneal space and the myopectineal orifice, where the hernias appear, with an improved view. We can address medial, lateral, and femoral hernias and place a big mesh covering all this space, avoiding missing hernias and avoiding to the main nerves that cause chronic pain, with the advantages explained before. In this meta-analysis published last year, showed that there was no differences in recurrence rate between Liechtenstein and laparoscopic technique, and clearly there were less acute and chronic pain with laparoscopy. The trial sequential analysis reported that further studies are unlikely to show differences between techniques regarding recurrence. I'm not going to make any difference between TEPP or TEP, because both are different ways to get to the same space and have similar outcomes. The choice of one or another should be based on surgeon's experience, skills, and education. The advantages of laparoscopic approach are even more clear when we speak about bilateral inguinal hernias. You can solve both sides with only 3 small incisions. It's the choice too in women and in femoral hernias, and of course in recurrent hernias previously operated by an anterior approach. But not all is wonderful. Laparoscopic surgery has some drawbacks. Needs general anesthesia, specific equipment, not always or everywhere available, and it has higher hospital costs compared to Liechtenstein repair. But these differences decreases when total community costs are taken into account. It's a difficult procedure, needs some skill, and there is a possibility of major complications like vascular or visceral injuries, especially in the first cases. The learning curve is long, more than 50 or even 100 procedures depending on the author. This is because most surgeons don't know anything about the preperitoneal anatomy, and there isn't good training models to perform the procedure before you are going to do in the patient. And only few surgeons with enough expertise are available to teach this procedure. Attempting to shorten the learning curve and avoiding complications, the critical view of myopectomy orifice has been described for Jorge Daes, the next speaker, as a specific and standard way to perform the procedure in 9 steps, making it easier and safer. Standardization of the procedures step by step improve the surgeon's skill and shorten the learning curve. Following the steps, the surgeon must see the Y inverted and 5 triangles, always, and put a mesh covering all the possible defects. In conclusion, laparoscopic surgery has many known advantages, can address all kinds of hernias, has faster recovery, less pain, most patients are suitable for the procedure. But we have to improve the learning process if we want that laparoscopic approach becomes the procedure of choice. And the best way to do it is the standardization of the teaching. But it's not for all patients, not for all type of hernias. If you see these giant hernias or loss of the mind inguinal hernias, it's impossible to do it, except Dr. Morales perhaps, to do it. And it's not for all situations in low-income settings on emergency surgery, and not for all surgeons. It needs expertise. I think the tailored approach is the right way to perform hernia surgery. Patients like this may be perfect for laparoscopic repair, but surgeons have to offer the best technique depending on the type of the patient, the type of hernia. If it's an emergency or elective surgery, where they are and what are their knowledge and skills. Thank you very much.
Many thanks, Pilar.
Thank you.
Very nice talk, very nice talk. And we can go, and now it's a very great honor to introduce Jorge, best friend. And one of the main topic, I believe, in our life as surgeons, because the real art of the surgery is to make easy the difficult things and not vice versa. So the talk of Jorge Daes is exactly on this topic. So please, Jorge, thank you for coming.
Thank you for the kind introduction. I would like to thank the organizing committee, especially Dr. Lopez Cano and Dr. Salvador Morales for the kind invitation to participate here. Let me look at this. Okay. Okay. So the ETEP access concept is defined as a set of maneuvers and strategies that are undertaken to enhance a usable extraperitoneal space for the repair of inguinal, ventral, lumbar hernias, and other procedures. What are those maneuvers and strategies? Well, remote access from the hernia, creation of a large space, flexible pore setup, and the division, sometimes, of its natural boundaries. A small history on ETEP. The TEP technique was described around 1992 on both sides of the Atlantic by McKernan, Fersley, and Duluc. We descended then to Memphis, where a Southern gentleman, Dr. Guy Beller, was teaching one of the most popular courses on TEP. The technique that Dr. Beller has taught since, and we have taught in many immersion courses, has remained unaltered for 25 years. But to our disappointed, it has a very low implementation rate. And the reasons for this difficulty to teach and learn the technique are a limited surgical field, a restricted pore setup, low tolerance to pneumoperitoneum, and poor ergonomics. Nonetheless, we believe that, at least in theory, the TEP technique was the closest to ideal. So one sleepless night in 2009, while we were considering ways to improve the technique, we came up with the concept of the ETEP axis. Small e stands for enhanced or expanded. Very soon, we repair over 30 hernias with the ETEP approach, most of them in very difficult cases, and we published our results, first in Spanish and then in English. Then we conducted many immersion courses, and we noted an early implementation rate of the technique. We move on to repair other hernias, like very low ventral hernias, M5 mainly, and some Spigelian hernias. And we published the first ETEP approach for the repair of lateral lumbar hernia, mainly L4 hernias. These are the two most common pore setups for the ETEP approach for inguinal hernia repair. And the blue stripes represent all the places where the initial incision for an inguinal hernia repair can be done. And the red spot signifies the place where the initial incision is for the classical TEP approach. But this technique would have remained a somewhat provincial technique if not for a group of very smart surgeons, brilliant and friends. We have dubbed this group the Band of Brothers. One of them, Igor Beliansky, described the crossover, allowing the implementation of the ETEP ribs and ETEP TAR for the repair of ventral and incisional hernias. The salient features of the ETEP technique for the repair of inguinal hernias are the fast and easy creation of the extraperitoneal space, the creation of a large surgical field, a flexible pore setup, tolerance to pneumoperitoneum, and better ergonomics. But to us, the main advantage of the ETEP approach for inguinal hernia repair is that it facilitates the steps to establish the critical view of the myopectineal orifice, especially step 5 in very large inguinoscrotal hernias, like in this one, in which the sac extends all the way to the scrotum. We are able to separate the sac progressively from the elements of the core without really touching the elements of the core until we find what we call the bluish transparency that allows to separate the sac from the elements and then divide the sac. Then we are going to deal with the distal sac. But we continue now with parietalizations of the elements of the core. Sometimes we have to proceed cephalad with that dissection, like in this case, further cephalad, to avoid the elements of the core from hanging in the space, forcing the tenting of the mesh over them. And this is very easy to do with the ETEP approach. It also facilitates step 8, is placing any mechanical fixation, like this one, to fix the distal sac, in this case, or the mesh, well above the interaces line. This is the critical view of the myopectineal orifice, as seen with the ETEP technique. In this case, the patient has a total disruption of the posterior wall, and ETEP also facilitates step 9, the placement of a properly sized mesh like this one, extra large 3D Max bilateral hernias, and its fixation with sutures and tacks. There are other applications for the ETEP approach for inguinal hernia, especially when the distance between the umbilicus and pubic tubercle is short in patients with previous pelvic surgeries, in complex cases like large inguinoscrotal, sliding, or incarcerated hernias, and patients with obese or post-bariatric because it allows to go over the panniculum and to implement the robotic extraperitoneal approach. But let me tell you, if the technique you are using currently, you are able to establish the critical view of the myopectineal orifice and to repair most of your hernias, you don't need to change it. But learning the ETEP access will open a new world for you to the extraperitoneal repair of ventral, incisional, lumbar hernias, and other procedures, such as the triple neurectomy. Now, candidly, these are not techniques to learn over the weekend. They require a profound knowledge of the anatomy, including the natural boundaries of the extraperitoneal space and the neurovascular structures, and also proper training that ideally should include cadaver dissection and a proctor. But Mr. Chairman, let me answer the question that was assigned to me as the title of my presentation, to borrow from John F. Kennedy, to say that when we embraced the minimal invasive revolution, despite the stark opposition of the establishment, when we adopted the laparoscopic inguinal hernia repair, when we expanded the extraperitoneal space, when we did all those things and others, we didn't do those because they were easy. We did those because, despite them being hard, because in the process of doing these techniques, we became better surgeons, more dexterous, more knowledgeable of anatomy and technique, and in the end, we improved patients' lives. Thank you.
Thank you, Jorge. We're going to move to the last presentation before to go into the discussion. We have the opportunity to have with us Conrad Balliser from US, and he's going to cover everything related to robotic inguinal hernia repair. It will be another important factor to analyze today, and what is the role of robotic in inguinal hernia repair. So Conrad, thank you very much for being with us today.
Thank you very much, Professor. And while I most certainly would rather do this amidst all my friends around the world, I congratulate the organizing committee for not allowing COVID to thwart your educational efforts. So I am super honored to be here. I'll be talking about robotic inguinal hernia repair and essentially the evolution of how this came about. These are my disclosures, which are actually absolutely germane to the topic that I'll be covering. I always disclose that I've never made a difference between laparoscopy and robotics. There's nothing non-laparoscopic that I do with the robotic instruments. And I think Dr. Barry McKernan said it best when he introduced Lap Chole into the United States, stating that we're simply taking modern technology and doing the same operation. And I would challenge any of you in the virtual world to be able to decipher which image was dissected, which groin was dissected with the laparoscopic instrument versus the robotic instrument. And it's been my point this whole time, when you are comparing two exact same procedures, you're going to be hard pressed to find a difference. And this has certainly been recently published in the Rival trial out of the Cleveland Clinic in the EHS QC in March of 2020. It's something that I suspected and something that they concluded. But to digress, how did we get here to this wonderful world of MIS inguinal hernia repair? And I like to credit of standing on the shoulders of giants who have brought this wonderful technique into the armamentarium of thousands of surgeons across the world. Their initial iteration was somewhat hampered by the lack of technology and the lack of adequate mesh product, where they simply utilized a clip device and closed the hole from a transabdominal position. When that didn't work, they plugged the hole and then they just covered the hole with intraperitoneal mesh. But I suspect that they were unhappy with the outcomes that they derived, probably attributable to the fact that we were not adhering to the well-established principles of the pioneers that came before us, like Professor Reeves, when he originally pioneered the open preperitoneal approach to inguinal hernia repairs. But these pioneers forged on. Somewhat coming up with a laparoscopic TAP technique, and then subsequent to that, the laparoscopic TAP inguinal hernia repair. Not surprisingly, also predictable, the emergence of laparoscopic inguinal hernia repair was super contentious, with debates occurring in conferences worldwide. One such debate, highlighted by Professor Veller, in which he had a contentious debate with Dr. Georgie Wantz. But after the debate, Dr. Wantz approached Dr. Veller in private and stated, "Guy, don't tell anyone, but if I had a hernia, I would want you to do it laparoscopically." And Professor Veller always states that it was at this point where he knew that he won. But the question is, have we won? In the United States, unfortunately, the adoption of lap inguinal hernia repair maxed out at 25%, and that's somewhat generous. This has been changed dramatically by the emergence of this robotic instrument into the inguinal hernia space, with this massive adoption that you are seeing in the United States today. So the question is why this happened in such a short time. I remember having a little conversation with my mentor, Professor Carbonell, and our adoption of the robotic instrument somewhat coincided. And in 2012, early on in our curve, I asked him what he thought about the robotic instrument, and he stated, dude, you know, the robotic instrument is a perfect tool to conduct a complex case because it makes those complex cases easier. Which to me begs the question, well, if it makes complex cases easier, doesn't that mean it would make more basic cases easier as well? And I make no apologies. I am the typical surgeon who will take that path of least resistance from point A to point B without sacrificing outcome. If you showed me an endoclip, I'd probably use that before the purse string device. Give me a stapler before hand sewn, a position device before using the transfascial lap guided sutures for initial placement of mesh. I used to do laparoscopic inguinal hernia repair before I adopted the robot, but what I found out early that not only the conduct of basic cases were easier, but I was able to approach more complex scenarios. This is someone I would typically have offered an open approach, the strangulated femoral hernia, but now I'm perfectly comfortable offering an MIS approach to my patients, and I can dissect a much larger space, place a much larger mesh in the form of Reeves, or in bilateral inguinal hernias, mimic the operation of Stopa and his giant prosthetic reinforcement of the visceral sac. This is a patient multiply recurrent after open and laparoscopic failures. This is probably someone in the past I would have referred out. You see bowel content within this multiloculated right inguinal hernia, stuck to previous mesh, stuck to previous fixation devices. I like to make a high peritoneal incision. It's easier for me with the robotic instrument to stay in that true preperitoneal space. I like to create that volcano sign. And one of the differences between the robotic and straight stick platform is that I can control all my arms. I can control exactly where I want the camera. I can utilize the fourth arm as a static retractor for these large inguinal hernias. And then I can follow the dictum of Professor Diaz and Professor Felix, achieving that critical view of the myopectineal orifice every single inguinal hernia repair that I do, whether it's basic or complex. I like to placate the pseudosac to Coopers and large directs, and then place this extra large heavyweight 3D Max to completely cover the myopectineal orifices bilaterally and ultimately reperitonealize the mesh. Which brings up to the cons, and the obvious elephant in the room is the cost of the platform. I never make any challenge that the robotic instrument is cheaper than the lab, because that simply is not the case. But one thing I can tell you, my friends, I don't make a single dollar more if I do this robotically, but most importantly, my patients are not charged a penny more for the use of the robotic platform. So that being said, it's no longer a question for me of whether I can do it lab versus robotic. Let's turn that question around and ask, if you were the patient, or with all things being equal, or the patient was your family member, what would you want? And the answer is simply Darwinian in principle, or perhaps American, where we Americans like to have the best of what's available. And I'm unapologetic to clearly state that simply the robotic platform is just a better tool in terms of visualization, the ability to articulate and achieve a level of precision that you simply cannot reproduce with the straight sticks, in my opinion. And I reject the conclusion in the rival trial that failed to reveal an ergonomic difference. My contention is, if you don't see the benefit of ergonomics with the robotic platform, you are simply doing it wrong. And to illustrate this, the only meeting I attended this year was that of Yuri Nowitzki's. Second day into the meeting, I was run over by a snowboarder. I broke my left clavicle. When I came home, I was operated on March 9 on post-op day 2. Later, whether I can perform 2 robotic inguinal hernia repairs on post-op day 4. And I can tell you without a doubt that there's no other platform I would have been able to execute this case 4 days after clavicular surgery. So here's the ultimate question that I would like to pose to you is, if you were the patient or you were the surgeon, would you rather use this instrument versus this instrument versus this instrument? Thank you so much for the organizing committee. Everybody keep safe, and thank you again for the opportunity.
Very nice, very nice. Thank you, Conrad, for this speech. Salva, we are Rolf.
No, he's watching.
Okay, because in my program I don't have Rolf, and this is the reason why I wrote to you.
Oh, yeah.
Salva, you can start the discussion.
Okay, so thank you very much. Thank you, everybody. I've been getting some questions from the audience, but I think we will start with some questions from Gianpiero and myself. And I'm going to, why don't we go each by one and asking some questions, and starting with Ralph. One of the things that Ralph, do you think that the problem, of course, there is 3 problems. One is the surgeon, one is the second one is the mesh, and the third one is the fixation. So we are, everybody's pointing out, those who doesn't believe on those techniques using a mesh, that the mesh is the problem. But the question is, who do you think is more important, the mesh, or is more important the surgeon and the fixation? Because what I think is, like, if a surgeon do a wrong surgery and fix the mesh in the wrong place, is the main problem. It's not the mesh. And of course there is a scar reaction, there is a fibrous, but I think that this is the main issue. It's not a problem of a mesh. What do you think about that? What would you think? And of course, the rest of you can talk about that. What do you think, Ralph?
I strongly agree with you. Of course, I think the biggest, or I think the most important thing is, of course, the surgeon. And the surgeon has, of course, the biggest impact on the quality of the surgery. And finally, of course, we see so many cases as recurrences of chronic pain patients, and we don't know exactly what was done before. Normally, of course, I think I miss sometimes a kind of standard of the procedure. I miss sometimes, of course, a very strict protocol how to deal with. I think you might be absolutely right. about the meshes. Might be that's not the major issue, but of course, we know not exactly everything about meshes. And of course, the ongoing process to develop new meshes or partly absorbable or completely resorbable meshes, that's something which is, of course, what is the background? What is the reason for? And that's why we should keep it in mind that we are not, of course, on the end point of our knowledge. And might be that we create some new topics and new problems for the future. Might be. And of course, everybody is knowing if you have a recurrence after a previous mesh repair, it's much more demanding, much more challenging comparing to a previous or primary repair. If it's done properly, and you can do whatever you like. And if the surgeon has a very good quality, of course, you will get, of course, good results.
Salva, I would add another question to Ralph. This is, of course, it's true, but don't you think that there are two aspects? The first one is that all the surgeon, the normal surgeon that do a simple primary inguinal hernia repair, that approach with the hernia mesh, they think that approaching with hernia mesh, with the mesh is much more easy than approach with the Schuldeis or Bassini. And this is the reason why the anatomy is not respected. And this is the real reason probably for the mesh. And the second aspect is that in the past, we are starting with the Bassini repair and Schuldeis repair for many years. And I don't remember at the Congress of European Medical Society in the 90s, quite never we talked about the chronic pain. Why?
I don't know the answer because I was too young for at that time. But no, of course, I'm joking. No, of course, you're absolutely right. And of course, the biggest factor is the surgeon by himself, definitely. And the knowledge of the anatomy is crucial. If you don't know where you are, you will never get to an end point or will have a good repair. So for that reason, of course, I know the skills for Schuldeis repair are even more demanding, and you need a very clear preparation. And of course, then you will get, of course, excellent results. And that's the point. And for finally, of course, the education is necessary, and that should start again with the anatomy. And if you don't know the anatomy, don't do any hernia.
Rolf, and for you that you said, well, I will do a Schuldeis, but in which cases will be your indication to use a mesh? I mean, which case you would say, well, this case, large hernias, female.
I think yeah. I think, of course, there's no doubt about it. If you have a weak tissue, or such a connective tissue disorder, you should choose a mesh. If you have a pantaloon hernia, if you have a combined hernia, if you have a femoral opening, you should choose a mesh. And of course, the posterior approach is even better than an anterior. That's nothing new. And of course, you have the possibility to tailor during the surgery. That's something which we have to keep in mind. And of course, you can do an open access, and then you navigate during the surgery to get into the prepinal space if you are familiar. And I'm very thankful to Manuel Lopez-Cano for his brilliant presentation to come up with these small insights. And of course, it's not a blind preparation. It's of course visible, and everybody who is joining my courses or my unit in the hospital, they will be, of course, see everything. That's not a secret, I think, and the preparation is clear. And of course, there is absolutely an indication, but on the other side, there is also an indication to learn the pure tissue repairs for these young patients with small hernias or mid-size hernias, because, of course, why should we need a mesh for these cases? in young patients.
So, Rafa, can we conclude, because, we have had in Hamburg the meeting to define the indication of shoulders repair. Can we say, and to give the message that for the so-called small hernia, it means L1, L2, and we can use safely the shoulders approach? Can you say?
Yeah. I totally agree with you. Of course, in my personal strategy, of course, I use this and or I follow this aspect. And of course, so we prove it during the surgery. And of course, if I think you can use the ultrasound before to navigate already. You have the information about all the risk factors. Is there a familial background? Is he smoking? And all these things. Then you can choose the right technique for the right patient. And of course, don't adapt the patient to your technique. Please adapt the technique to your patient.
And Salva, I believe I would ask to you and to everybody, due to the fact that this is the reality, the problems with the meshes are all over the world now, very spread. So many lawyers, many companies that talk against the mesh. So the message for the young surgeons that in this moment are connected with us is that they must have to learn the open approach, and even without mesh, because independently the fact that the mesh is posed by open or laparoscopy or robotic, the critic is on the mesh, is not on the technique. So the lawyer talk about the mesh, not talk about the robotic mesh or laparoscopic mesh. So I believe, and I believe that you are the president of the Spanish Hernia Society, the Spanish Surgery Society, and so for the young surgeons, this message is very important. The message of Ralph Lawrence: please keep to learn even the simple suture technique.
Yeah, well, I think you're right. I mean, the problem is what we said at the beginning. The problem is not. I mean, the problem is an improper way of placing a mesh and fixing the mesh in the wrong way. And you have to be trained for an open. You have to be trained for a mesh. And with things like a mesh, you throw the mesh and things out, and you put stitches and things are solved. And then is where the problem from the mesh comes. And I think that is important. But I will move to Manuel, because something was raised by Ralph, very interesting, that you mentioned that if you have to select an open and place a mesh, you prefer the posterior approach. And that led us to Manuel. And this is important to analyze, because one of the sentences in the international, the hernia guideline, the international guideline, said that the preferred technique for open mesh repair is Liechtenstein. But at the end, there is another sentence that says, still there is no evidence, but posterior seems to be even better. But there are a lack of training and education on posterior approach, in posterior open approach. So you are very convinced, right, Manuel, that it's better to do a posterior approach than an open Liechtenstein approach? Just to, is it a question of a lack of evidence, or is it a question of a lack of training?
Yeah, sure. There is a lack of, for me, the posterior approach is the election. However, I didn't place in my presentation the hernia search, but if you look at the chapter regarding preperitoneal approach, the statement is that we can use this approach in experimental setting. Again, I think there is a total lack of knowledge of this approach, at least following an open approach. Because it is interesting, even the panel, because in this panel we have 5 talks, and 4 talks are talking about preperitoneal approach: robotic, laparoscopic, open, and the retromuscular approach doing by Jorge. I think that, I work in an academic hospital, and we try to prepare our residents, in surgery, learning all options in the open and the posterior preperitoneal approach. However, I think that the anterior approach is another technique that a general surgeon should know because he or him or she should know an anterior and a posterior approach. Anterior, we have only one with MES. Only one that you allow me is Liechtenstein, excluding, of course, anatomical procedures. But posterior, we have different approaches, open, laparoscopic, and robotic. But I think that a general surgeon should know an anterior and a posterior approach. And a specialized in abdominal wall surgery should know an anterior and anatomic and a posterior laparoscopic, robotic, and open. Is my thinking about that. I don't know if I answered your question, Salva.
Yeah. But there is one point that it was pointed out in the chat is, what about local anesthesia and posterior approach? Because this is one of the points that people say, well, the good thing about Liechtenstein, you can do perfectly by open, but what about this? I mean, you have experience. What do you think? What is the evidence on local?
There is no matter regarding the whole discussion if we should do that with local or the advantages of an anterior approach is you can use local, and disadvantages posterior approaches we cannot use local. Today, I think that the best approach, an aesthetic approach for a patient with an inguinal hernia repair, is a general anesthesia with a mask, laryngeal mask. Even with this technique, we can use in ambulatory surgery. I think the local anesthesia, I did in the past some patients with a preperitoneal approach, of course, selected patients using local anesthesia, but this is not a good approach, is not comfortable for the surgeon. I think today with the new anesthetic evolution and so on, we can use a laryngeal mask with a general anesthesia for all procedures related with inguinal repair, anterior or posterior.
And there is, Manuel, there is another important point for the open preperitoneal approach. First, that I strongly believe that is a learning curve for the laparoscopic approach. This is without any doubts. The second is much important, is the possibility to treat the postoperative chronic pain, because the postoperative chronic pain that in my vision is dated from 2 points, the triplenurectomy and the removal of the mesh and plug. If you don't know the open preperitoneal approach, you cannot do the correct triplenurectomy, because the triplenurectomy in this previous scar field is not possible or is not safe. So you have to do the triplenurectomy on the psoas muscle, on quadratum lumborum, in other terms, in the virgin field. And you can do this by open approach in the preperitoneal space. This is another very important point.
And also when we are learning about the posterior approach, the preperitoneal approach, at least in my case, I was trained in open preperitoneal, but I was also trained in laparoscopic and now in robotics. And I increased my learning regarding the nerves and the anatomy of the preperitoneal space following the laparoscopic or robotic approach. I think that we need to combine all the techniques, and the residents should learn all these kind of techniques, at least if they are able to learn, because if the resident is working or is learning in a low-income country, probably he or she needs to learn an open anterior and an open posterior approach. But if you are working together with Conrad, probably we need to learn robotics and laparoscopics and open preperitoneal and anterior.
Yeah.
But Manuel, you raise an important issue that it is in the international guideline that I would like to point out, is about the anesthesia, which is one of the complaints of the people. They say that you say that it seems like in the past, regional anesthesia was the king. And we see in this guideline that say the regional anesthesia over 65 is related to more medical complications to the patients. And then you move what you say. Anesthesia, general anesthesia is not the general anesthesia that we learned in the past, is with a mask, and it could be combined, and it's better for the patient if we have a good anesthesiologist. So we need good surgeons to decide what to do, good surgeons to place a mesh in the proper way, to fix the mesh in the proper way, and work with a good anesthesiology. So the problem is training at the end.
Yeah, sure, for sure.
So Pilar, I have a question that also was raised on the chat, that how do you convince people that laparoscopic approach is not a very expensive procedure, that you can perform it with, because at the past, people thought you need a special mesh and a special fixation with a special trocar, so with a special 3,000 euros to do a unilateral TEP. But I would like to raise this issue because this is one of the complaints worldwide, because we have people from all over the world. I see so many countries, and I would like you to convince them that you can do a proper, cheap laparoscopic approach.
Thank you. It's a very interesting question. But first of all, I want to emphasize something about the presentation of Manuel. Preperitoneal open approach is the best way to address an inguinal hernia in emergency surgery. It's the best way to do it. And I think it's very important to all the people to know it, because most surgeons want to make, if they need make a intestinal resection, need to perform a laparotomy, and it's avoid if you use preperitoneal open approach. And I am going to answer your question. Why is how can I convince to the other people to make laparoscopic surgery not expensive? If you have some experience, you perform laparoscopic surgery without any extra devices, without balloons, without any special type of mesh. You can put fixation only with, no, I don't know, in this moment, pegamento?
Glue.
Ah, sure. With glue, it's not expensive, and even you don't need fix the mesh in some cases. And if you take into account the costs of post-operative recovery and sick leave and etc., this amount is enough to cover the extra cost supposed endorsed to laparoscopic surgery, in my opinion.
Pilar, we had another question from the audience, from the floor. What about the emergency surgery? So, because you told that it is not possible to approach with emergency surgery, and then we have a lot of questions about this.
I think only surgeons with high grade of experience can make it, because it's difficult. It's a difficult approach. If you need perform intestinal resection, you can make it, but it's difficult. You need to be a very, very skillful surgeon to do it. And if you have this experience, you can do it, but it's not for every people, I think. Perhaps Salva can do it, and in Spain there are some groups in Seville that performing it in emergency surgery, but I think it's not for always, for not every people.
Don't you think that at least beginning in a laparoscopy can be helpful, because you can do the diagnosis tool in order to check the bowel and to check the ileum? At least beginning, start, yeah. And after you can decide.
I agree with Giampiero that laparoscopy should be considered like a diagnostic tool, and then you decide how to keep
perform the repair.
Yeah, perform the repair. That's the good thing. So Jorge, I have a question for you.
Yes, sir.
Same question that I always, you know that I have a lecture on Taylor approach, and I say these cases, as a surgeon, you have to be able to do open, TAPP, TEP, whatever. So why I should go, because in a difficult case with a large scrotal hernia, you propose to do for an ETEP. I do TAP in those cases. Why instead of doing TAP, TAPP, I should go for an ETEP?
Well, first of all, I agree with you that the procedure of choice should be tailored according to the surgeon and his training, the local resources, the hernia, and the patient. Even if you have the perfect training and resources and the hernia is easy to do laparoscopically, if the patient has a limited physiologic reserve, especially respiratory, this is a patient for an open approach with under local anesthesia. So when you ask me why ETEP, I say because it compensates for the drawbacks of the classical TEP, which I consider that, at least in theory, is the closest to ideal, because you don't penetrate in the abdominal cavity, as we have not done in the 120 years of hernia history. We don't have to open peritoneum and close it at the end of the procedure, because it allows for local and regional anesthesia. Let me tell you, I've done some TEP and ETEP cases under local anesthesia and sedation, especially for patients with cardiac problems. It allows that. So those are the advantages, and the port hernia sites. Those are, at least in theory, advantage over the classical TEP approach. But as I said, if you're doing your TAP technique, and with that you can implement the critical view and repair your hernias, I wouldn't change your approach. That's my answer. But for us, it has made more easier to do the TAP technique, and we can say that many surgeons in our clinical immersion courses with limited experience in TEP, mostly they have experience in TAP, they adopt the ETEP technique into their practice somehow. We have statistics that show that almost 80%, at least partially, they implemented the technique into their practice. So it can be taught, it can be learned, it facilitates the critical view, and for specific cases that I presented, like the short distance between the umbilicus and the pubic tubercle, previous incision, a very obese or post-bariatric patient, many circumstances makes the ETEP approach attractive. So that would be my answer.
Very interesting, Jorge. What do you think about the differences between robotic and ETEP?
No, I mean, is for me or for Conrad?
For both, but for you, even for you.
Well, for me, robot is
it's much more easier.
Well, robot is a way to do it. It's an add to the armamentarium we already had. If I had the robot and it was cost effective, for sure I have my breakfast robotically assisted, even, because that's a wonderful tool. So, and specifically for ETEP, I don't think it's popular. It's more popular the TAP technique for robotic. But let me tell you, with the classical TAP technique, you cannot do it robotically. You need the ETEP to expand the ports, and we did that in the animal model, in the pig, with the robot, and it gives you an amazing space. But the problem is, half the surgery is doing the space. So once you create the space, adding the robot in that specific case doesn't seem attractive. That's why it's not popular, I think. But Conrad is an expert in that field, so I leave him to answer that.
Yes, because we have seen from Conrad Balazar the preperitoneal, the extraperitoneal space very, very easily prepared by robotic approach, and this is one of the reasons why I think that it's popular.
You know, I think the discussion typically revolves around robotics versus laparoscopy. For me, what's most important is who's doing the procedure. So if I was in Berlin and I wanted my hernia repair performed by Professor Lorenz, I would want a Schuldeis. If I was in Colombia, I would want a laparoscopic ETEP. If I had a giant inguinoscrotal, Professor Campanelli, I would want you to do your hug technique. So what's more important than the instrument is the operator of whatever instrument that they do that can perform the best approach within their toolbox.
The opportunity to learn from the expert.
Yeah. So, hello. So thank you very much, Conrad. Conrad, do you have you preferred any TEP, standard, no ETEP, standard TEP, robotic TEP, or someone is doing it better than TAPP, or it doesn't make sense at all?
So when I was trained, I learned laparoscopic TAP. I did TAPP approach for most of my inguinal hernia repairs. So the transition to do it robotically, the learning curve to do it robotically was very easy. I never did a TEP laparoscopically before the whole ETEP craze came out. As far as doing it TEP, my partner, actually, that's his preferred approach. He was a laparoscopic TEP surgeon, so he does it robotic TEP. But like what Jorge was saying, logistically, to have the arms with adequate and ports with adequate separation, he employs an extended view technique when he performs his robotic TEP procedures.
Thank you. Well, one of the things, the big advantage that I saw from robotic is two cases. One is multi-recurrent cases, and the other one is the obese patient. Because, for example, yesterday I did a bilateral TAPP for an obese patient of 40 BMI, and it was, the instrument bent, and it's such a problem. So I consider that, I don't know if you agree, that those are the cases that if you have a colleague next door, you should refer those to them to do those cases, those multi-recurrent and the obese patient. What do you think, Conrad? What's the cases that you should refer to someone doing robotic TAPP?
Again, I think that is super operator dependent. I can't imagine you, Salva, referring any complex inguinal hernia repair to the neighbor next door. This is truly operator dependent in what you're comfortable with and what you're offering to. Yes, I do believe there's an ergonomic advantage, especially that is more accentuated in higher obese patients. For me, I'm a short guy. I have relatively short arms. I could do the straight stick inguinal hernia repair, but ergonomically, it was difficult for me. There's no question, in my opinion, and I don't need any randomized controlled trial to tell me what platform or what instrument makes the conduct of that case more ergonomically friendly. That being said, again, there's amazing laparoscopic inguinal hernia surgeons such as yourself that could probably easily do cases just like you mentioned, and I would be perfectly comfortable with that.
And I have a question to Ralph. Ralph, do you think that these obese patient with 40 BMI, what would you do? Because dealing with the tissue and exposed tissue is complicated. So do you think these cases are for this open non-mesh technique, or you should do another thing? What would you do?
Normally, of course, I would choose for these patients an endoscopic repair because, of course, it's even much more beneficial because you have less wound complications, you have a better overview. And for that reason, of course, these patients are even more selected to do a mesh repair endoscopically, or, of course, I think that would be the best choice. And that's why, of course, my perspective is, of course, include all the techniques and allow all the techniques, because you have, of course, this possibility, which technique is for which patient the best. And of course, so you can select even more. And if you have, of course, more opportunities with an open anterior, open posterior approach, with an endoscopic approach, with an open pure tissue approach, then you are, of course, you can guarantee that you identify the ideal patient to your technique.
And I have a question for all of you. If you read the literature and the evidence regarding lightweight, large pore, heavyweight, small pore hernia, you see that there is a slight difference in open approach, that it seems to be better for this large pore hernia, but there is no much difference in the laparoscopic approach. So what is your trend? I mean, I want to see how do you, each of you in 20 seconds, 25 seconds, give me what would you do in terms of which mesh you use and why in that sense. Let's start from the beginning. Ralph, what do you prefer? Ralph?
Yeah.
If you have to select a mesh.
If I have to select a mesh, of course, I would choose a very, of course, sensitive mesh, which is, of course, stable enough, but it has a large pore mesh with all the characteristics which are, of course, elastic enough, and of course, so that you have, of course, the possibility to make, and that's something which is interesting. We have to keep in mind, should we close the defect or not? And that's something which is definitely not exactly known until now. And of course, we have to think about it, because we choose for all the ventral hernias, we right now recommend to close the defect and then put a mesh in. For groin hernias, it's the principle of being tension-free.
25 seconds, Ralph. Which mesh? We need to go through well. 20 seconds. Lightweight.
Okay.
Manuel.
A lightweight mesh. Definitely, yes.
Manuel.
Large pore. Large pore is more important than any. Yes.
Okay, 20 seconds each. Manuel.
Yeah, 2 seconds. Mid-weight, large pore.
Pilar. Pilar.
Midweight in lateral hernias, and in medial hernias, I prefer heavyweight.
That's good to know. Jorge?
Most of the cases, mid-weight, large porous meshes, around 40 grain for a square meter. I reserve high weight for very large direct hernias. And let me tell you, we have to go over the weight and porous. There are so many biomechanical characteristics that we don't have into account, and they are as important. For example, the central rupture, the rib prolongation, the anisotropy of the mesh. There are so many. We have to learn much more beyond weight and large pores. Thank you.
Conrad?
My preference is regular weight, big mesh.
And the question why I ask this, because placing a mesh by laparoscopy, a large pore or a small pore is totally different. I mean, the skill needed, and this is what happened, and also in an open, and the advantage have been not demonstrated clearly in that sense. So that's the reason why I raise this question. And I want to go to Conrad and those who do a laparoscopy. What Ralph mentioned is if we should close the defect of a medial hernia in any cases.
Yeah, so that's an interesting question, and I've seen, as well as my friends have seen, increased complications with closing defects from the posterior view, and I attribute that to the rise of the emergence of robotic surgery. I'm a big believer. Just because we can doesn't mean we should. I know all our friends, Dr. David Chen. He tells me he sees at least 2 patients a week of patients who underwent robotic inguinal hernia repair with the defect closure, and now they are suffering from chronic pain. You know, we have amazing evidence to support the classic laparoscopic inguinal hernia repair without defect closure. So I don't close the defects. At most, I will obliterate a large direct inguinal by plicating the pseudosac to Cooper's ligament, but that's all I would do. I certainly, I think one patient who you give a life worth of chronic pain to makes that defect closure just not worth it for me.
Well, Salva, it was a very, very nice session, and we are almost finished. Just 2 words for my vision and my conclusion is that at the end, the problem is always the same. It's very necessary to be a skilled surgeon, a good surgeon, and knowledge of the anatomy. The tailored surgery is the correct approach. Not all the hernia, not all the men can be approached in the same way. So the hernia surgeon has to learn the technique that they can use for the patient. So not only one technique, it's impossible to do this. And this is very important to the knowledge of the anatomy and all to fix the mesh in order to avoid the principal problem that is the chronic pain. I believe that this is the conclusion. It is always the same conclusion, you know, on this topic, on this particular topic. For my part, thank you to you, Salvador, and thank you to Manuel for the organization, and congratulations to all the speakers and all the people that are participating. And
thank you.
Thank you.
Thank you. Thank you all.
Thank you.
Thank you.
We don't criticize the technique and just try to teach everybody in the right way.
Exactly.
So thank you everybody.
Nice words.
All together here. So I'll see
Thank you, my friend.
next.
Bye-bye.
Thank you.
Bye.
Thank you.
Salva and Manuel for organizing this wonderful virtual Congress, EHS 2020. I promise today no balloons will be involved, and I will introduce the session. Miss and Manuel for organizing. It started almost 30 years ago with Karl LeBlanc's lab IPOM approach. And it has been popularized all over the world for a very long time. But of course, the problem has always been the foreign body material inside the abdominal cavity. So in the last years, several new minimal invasive techniques have been invented, which allow placing the mesh outside the abdominal cavity. But on the other hand, still the lab IPOM technique is a very important one, and I'm very happy to have 4 excellent speakers here gathered with us, and it is now my big pleasure to announce Samuel Parker from London. He's working at the Department of General and Colorectal Surgery at the University College London Hospital, and he has published several fantastic methodological systematic reviews concerning ventral and incisional hernia repair, and he has been working on the ICAP classification of the abdominal planes, and this will be the topic of his talk. So Samuel, we are very happy that you are with us, and please, we are very excited to listen to your talk.
Thank you very much. Thank you very much. Let me just get it up now. Professor Rempold, absolutely honored to be part of this forum and this amazing virtual conference. So let me just get this sorted. So I'm going to talk about an international classification of abdominal wall planes, or ICAP as we like to call it, and I'm finishing a PhD at the University College London, as Professor Rempold has just mentioned. A big thanks to my supervisors, Mr. Alistair Windsor and Professor Steve Halligan. So what am I going to talk about? I'm going to talk about some published definitions in the literature that have been there for the last 20 years. And then I'm going to talk about a series of publications that sort of came out in 2017, and we had a big response in the literature from our primary article. And then I'm going to talk about a Delphi study that took place 2018 and 19 and ended up in the establishment of ICAP, an international classification of abdominal wall planes. Then I'm going to present ICAP itself, a little bit more detail about the transversalis fascia, which seems to be slightly complicated and difficult to grasp, and then a bit on conclusion and further work. So published definitions in the literature, well, if you look at the literature, there's just been several that have been published in the last 20 years, and they're all slightly different, and this creates confusion and ambiguity, and they're inconsistent, and that peters down into clinical practice, and we're not calling the abdominal wall planes by the right terms. And it goes up all the way up to 2019 with the International Endoscopic Hernia Society publishing this description here of the abdominal planes. And they defined retromuscular as posterior to the rectus abdominis, oblique muscles, and peritoneum. So what does that mean? Is that intraperitoneal? So we need to be precise with our definitions. And perhaps the best three definitions known are Andrew Kingsnorth, 2004, published this definition, onlay, inlay, and sublay. Sublay, he said, was retrorectus above the arcuate line and preperitoneal below the arcuate line. And that's fine, no problem with that. Ulrich Dietz then published this 2007, actually in a urology journal, introducing the term underlay and IPOM, and again creating a little bit of confusion about the names of those planes. Perhaps the best known classification system published 2012 by the European Hernia Society. They got rid of the terms sublay and underlay and introduced retromuscular and preperitoneal. But I wonder if, since the publication of the transverse abdominis release in 2013, the term retromuscular then becomes ambiguous and slightly difficult. As you go lateral to the semilunar line, you can be retromuscular because you're retro-abdominal strap muscles, and therefore you're entering a different plane but calling it the same name. So we discovered this after sort of assessing the state of the literature in 2016-17. We published an article in 2017 in the World Journal of Surgery, just sort of saying that these are inconsistent, and it really frustrates research and frustrates clinical practice. This was responded to by Brian Jacobs and Philippe Meissems. They published a survey that they carried out with the International Hernia Collaboration and showed indeed that surgeons in clinical practice use different names for these planes. Mike Liang and Julie Holohan then published their classification series, and this was indeed different to the one proposed by us and the International Hernia Collaboration. So the three centres got together, and we had an idea to try and standardize the nomenclature for the abdominal wall planes, and we decided to do a Delphi study, including 20 panelists throughout the abdominal wall reconstruction field and expert surgeons to help us decide on the names. Delphi methodology means that all panelists had to stay anonymous throughout the study, and panelists had to reassess, deliberate, confirm, and alter their responses during the study. Consensus was defined as terms that achieved 80% or more, and terms were removed if they achieved less than 20% of the vote. These are the panelists. They've all been fantastic to work with. I'm very grateful to all their feedback and their votes. And there was a lot of energy going into the study, and I really and enthusiasm from all the panelists. It was great. Professor Steve Halligan, one of my supervisors, and I were study facilitators. I haven't got enough time to go through the results of every round, but these are the results. Importantly, some delay and not in the classification system. We did have to remove one plane, plane G, from the classification because this was actually continuous with plane I, which ended up being called the transversalis fascial plane, and not its separate plane and not separated by any anatomical barriers. So we've devised nomenclature for all 10 abdominal planes, both planes commonly and not commonly used in abdominal wall reconstruction, because we don't know where the specialty is going to go. So this is the classification system in a single diagram, and was published in the BJS at the end of 2019. I just want to touch on a couple of things. The retromuscular plane is a name that we use when we're putting a mesh from the rector rectus plane to the transversalis fascial plane, and when we're going behind the muscles from behind the rectus, behind the strap muscles. So we've done a TAR. There is a description of each plane in the publication, so you can read this anatomical description. Just want to talk a little bit about the transversalis fascial plane. This is the plane that gets the most sort of scrutiny when I present in seminars and lectures. And if you look at the anatomy books, Drain's Anatomy, it's described as a thin fascial layer below the abdominal wall muscles and superficial to the preperitoneal layer. And that's also the same description that Mike Rosen gives it in his Atlas of Abdominal Wall Reconstruction. But I think it's more practical or pragmatic to think about it in two parts. As we do the transverse abdominis release and we move laterally to the semilunar line, we come across the surgical transversalis fascia. Then there's a sort of more anatomical or theoretical transversalis fascia. We know it's there in the groin. It makes up the posterior wall of the inguinal canal. I've done some anatomical dissections with Johan Renard. As you go superiorly, you can peel it off the rectus muscle. It's difficult to separate it from the posterior rectus sheath, but I think it's been achieved by anatomists in the past. But we have to appreciate at the moment that this is probably a more conceptual part of that plane. It might get used more in the future. So to conclude, as abdominal wall reconstruction becomes its own specialty and as ventral hernias become more complicated to repair, probably because people are getting kept alive and there are subsequent recurrences and obesity is a problem, we need to have a nomenclature system that is clearly defined for the abdominal wall planes. Using Delphi methodology, we've devised a standardized nomenclature system, and ICAP will prevent confusion both in the clinical setting and also allow for rigorous, unambiguous research. I just want to talk a little bit about future work. ICAP can indeed change and flex as new techniques evolve and new planes are utilized. There are miscellaneous reports in the literature for repairs of Cocker's hernias in the right upper quadrant where they go from the retrorectus space into the interoblique space laterally, and that could be indeed a plane used more in the future. You could indeed go from the anterectus space to the interoblique space as abdominal wall becomes more complex. So we published this at the end of 2019. We're very grateful to the propagation of this publication on social media, and we really hope that it's going to be endorsed by the American Hernia Society. It's been endorsed by the European Hernia Society, and we're very grateful for that. Thank you very much. Do I stop my share?
Thank you, Samuel. So, are there questions now, or
at the end of the session?
So it's now time to move on.
Yes.
The next speaker is Salva Morales Conde. I don't have to introduce him. Everybody knows him. He has been our Secretary General for now almost 6 years, and he has been a fantastic laparoendoscopic surgeon, not only in the field of hernia, but also in the field of colorectal surgery. And he has done so many publications in both fields, colorectal and herniology. And he will talk about IPOM with a question, no longer useful or have a new role. Please, Salva, we are very excited to hear your talk.
Thank you, Wolfgang. This is a very interesting topic to analyze because there is a lot of discussion about this. Well, it's always been a discussion since the beginning. Well, IPON, as it's been described, is just placing a mesh. And when we think about IPON, what come to our mind is like cases like this. This is a patient that I reoperate because of another entity. I was operated by me like 5 years ago. 5 years previous to the surgery that I performed, and what I found after removing the adhesions was this: the mesh was shrinked, a lot of tuckers, and that was what people think when we analyze what IPON is. But the question is, this is no longer useful. This is the question that we brought in this lecture. If we talk about classic lab IPON, the one that comes to our mind with this picture, I would say that is no longer used. Yes, it's no longer used. But if we talk about lab IPON itself, the question of placing a mesh intra-abdominally in contact with the bowel, I will say that no, is useful, and I will explain why it's useful, this technique. And I will explain why this move from this classic IPON into a lab IPON itself, and why there is a reason to place a mesh intra-abdominally, and there is a room for this type of technique. The first question that we have to analyze is this classic lab IPON that is not useful anymore, it was such a bad technique? And this is a question. So we are moving into something that we don't like, but if we analyze the evidence and we compare open surgery with classic IPON, and we analyze every items like complication, pain, recurrence, hospital stay, return to normal activity, quality of life, and cost, and we go through these, and we analyze all the meta-analysis, and we analyze all the evidence beside meta-analysis, and we analyze and we redefine everything, like the seroma, that it was set like as a complication, and I published this paper in 2012 in which we redefined what a seroma is, and if it was an incident or it was a complication, then the answer changed totally of what we think. Pain and recurrence, no difference. There is no difference between open surgery and the classic IPON. But if we move into wound infection, there is so many advantages of using the classic IPON over the open technique. And also in hospital stay, from evidence from meta-analysis and also for large register, IPON reduced significantly the hospital stay compared to open approach. Quality of life, there is also an improved quality of life, not at long term, at short term, and this is due because you reduce the morbidity of the surgical wound. And at the end, if you see this chart, you see that in the literature, classic IPON was related to more bowel injuries, but the rest of parameters, either there was no difference or it was better with the classic IPON. So at the end, what we know is this classic IPON that we don't want to use any longer seems to have excellent results based on what is published in the literature. So, but why to move from this? And the reason is not because evidence, it's because we don't like to see this image. We don't like to see this mesh shrink in the abdomen. We don't like to see this type of adhesions to these terrible tackers, and we don't like to see long-term results like this one, in which the mesh has created a bulging is introduced in the sac, and the patients mention that they have this bulging that we call pseudo recurrence. So for this reason, and not because of the evidence, we say that we don't want to keep performing this classic IPON surgery. So what is the difference between this classic IPON and the IPON that we are performing in 2019 and 2020? What is the journey that we have gone through to say that there is reason to work and to perform IPON? The main reason is because the new IPON is not just placing a mesh to cover a hole, it's a minimal invasive abdominal wall reconstruction. We didn't want this image, and for that reason, in 2007, it was published by the group of Eliche Lala, How to Close the Defect, and that was the start of changing the classic IPON into something different. That was called the IPON Plus, and the advantage is, besides reducing the number of seroma, it was said that increased the functionality of the abdominal wall because you reinforce the abdominal wall and you avoid those pseudo recurrence and bulging after the surgery. And that is the importance of this IPON Plus. From the beginning, we moved our technique. We moved to mimic open surgery. We moved from this transfascial suture that was created in tension to do a running suture to close those defects. So by changing the technique and improving how to close the defect, we start having excellent results. So basically, the main difference between this classic IPON and the IPON Plus, which means the steel placed in a mesh, we saw that in a systematic review in 2014, that there was less recurrence, less bulging, less seroma, and more satisfaction of the patient. So we were offering even better result with this IPON Plus. And in 2019, it was published a paper comparing this IPON and IPON Plus in terms of quality of life. And it was demonstrated in a prospective randomized trial that this IPON Plus shows an advantage. So the answer to this classic IPON, which has excellent result based on evidence, is that IPON Plus, that means closing the defect, was going to be so much better than this classic IPON. But still, if you ask me, is useful this IPON Plus? I will say again, no, you shouldn't do it. It's no longer useful, this IPON Plus. And the reason is because we follow our patient. We perform CT scan to our patient, and I'm sure you've seen this slide before, and you see how 30 days after the surgery with a classic IPON Plus, like closing the defect, the muscle in the middle line were closed. But after 1 year, if you perform a CT scan, the linea alba start opening. So that's the reason why we analyze the results. We analyze the rate of recurrence. We analyze the rate of bulging. We observe that we have a 6% of recurrence and a 20% of bulging after the IPON Plus in long terms. And beside the chronic obstructive pulmonary disease, there was factors like large hernia with transfer defect of 5 to 9, in which we observed that it was not a good repair. We don't reestablish the linea alba at long term because most of the cases of bulging and recurrence was related to this size or transfer diameter. So, and that's the reason why I started working and thinking. The reason was so easy. We were joining together in linea alba fibrous tissue with no possibility of creating a scar. There was no possibility of having a healthy linea alba, new linea alba. So that's the reason why I start opening the muscle, the posterior fascia of the muscle, flip them together, suture them together in the linea alba, and then this IPON, this new mesh, will mimic the new posterior fascia of the muscle. And that's the reason why we moved that. And by doing this and making this incision, we were releasing the tension in the linea alba. So we guaranteed that we were going to have better results. We observe our patient, we see what happened, and you see the green line was the new technique, this LIDA technique, compared with those cases in which we just closed the defect. You see that there was a slight difference of the distance of the rectum muscle after a year with this LIDA technique compared with the rectum muscle that we joined together by performing this IPON Plus. So no tension, less pain, and at the end what we got is better results and at the same time less pain because there was less tension. So this is the advantage of 2018 with this new technique. It was still an IPON because we were placing a mesh, but we were doing this abdominal wall reconstruction. We still were placing the mesh, but in another way. And there is another thing. We still didn't like these tackers. But by reinforcing the linea alba, we can afford to reduce the strength of the fixation. Based on the study of Holinsky, you saw that the strength of this absorbable fixation device was less than the standard tackers and the standard suture. So the good thing is, like, moving on with this technique of reconstruct the linea alba, we can place and fix the mesh just with absorbable device because there was no need of such amount of strength to fix the mesh. So this technique was closing with no tension, was a long-term abdominal wall reconstruction, and at the same time we can fix with absorbable fixation device that also are related to less adhesions, and those are the advantage. Of course, we still have a mesh, but look at the difference. These two are IPON. These two are the same technique, but look, this IPON, this classic IPON, with this new IPON, in which we still have a mesh here. There is no fixation device, and the linea alba is reconstructed. So still there is longer, indication for this technique today? No. There is indication for this technique today? Yes. Of course, there was some solution that we will talk. The lab supply to avoid this mesh interabdominally, published by Rainpole, by Wolfgang. The Milos technique, published by Wolfgang. And also the ETEP technique that is going to be analyzed by Victor Radu in the next talk. So mesh could be avoided intraabdominally. But the good thing is IPO technique have excellent results, and it's been shown in the literature. And by doing these new changes in the technique, we can have an excellent results and also have an excellent reconstruction of the linea alba. So it's totally different. So what I say is classing like IPON, no longer useful. Exactly, no longer useful. But it's not a bad technique. Evidence say that it's a good technique, but it's better than IPON Plus. But the problem of the IPON Plus, it will open. So at the end, move into another options like the LIDA technique, in which you can reconstruct the linea alba in a proper way with a proper fixation. So new role, yes. Avoid classic IPON, just in very few cases, but this lab IPON itself with new technique and new ideas in mind really help you to do a different technique. Thank you very much.
Salva, thank you very much. Excellent talk. We have to move on, and I give the moderation over to my co-chair, Eduardo. Please go on with the next introduction.
Thank you, Wolfgang. Enjoying this symposium. Without any more delay, it's a pleasure to introduce Professor Victor Radu from Romania. His presentation will be Retromuscular Approach, the New Gold Standard. Victor, please go ahead.
Hello, everybody. My name is Victor Radu. I'm from Bucharest, Romania. It's a great honor for me to be part of this event. I have to answer a question. Can the retromuscular approach become the new gold standard in MIS ventral hernia repair? I hope I can give you a good answer. My disclosure. The international guidelines recommend the MIS the first option in ventral hernia repair. But we know there are a lot of issues related to lap IPOM. Difficult adhesiolysis, sometimes inability to close the large defects, the pain due to the mesh fixation, sometimes postoperative bulge and poor cosmetic results, and last but not least, the cost, which is very high. Do we have alternatives? Yes, we have, and my preferred is the ETEP and ETEP-TAR, the retromuscular approach. This technique was published by Dr. Igor Belyansky 4 years ago as a paradigm-changing technique by closure of the defect, place the mesh outside of the abdominal cavity, and minimizing fixation of the mesh. The indication of this technique is to fix primary ventral hernias, incisional ventral hernias, and also complex incisional hernias with multiple sites defects. The contraindications are related to mesh infection or enterocutaneous fistula. There are absolute contraindications and relative contraindications related to loss of domain and or dystrophic ulcerated skin. The principles of this technique are very similar with the principles of classical Rives-Toppa technique, which is the gold standard in open ventral hernia repair. I mean, it's about to connect three spaces: the preperitoneal space represented in the upper part of the abdomen by the falciform ligament, in the lower part of the abdomen by the umbilical ligament, the both retrorectus spaces, and the laterally to the semilunaris lines pretransversalis spaces. By MIS, we can connect to these spaces crossing over the midline. We will cross the midline above the umbilicus if the hernia is located in the lower part of the abdomen, in front of the falciform ligament. If the hernia is located in the upper part of the abdomen, we will cross over the midline below the umbilicus in front of the umbilical ligament. About port placement. As a general rule, we will place the ports medially to the semilunaris lines in the opposite part of the abdomen to the hernia location. Now let me present to you the key stages of the procedure. This is a hernia located in the lower part of the abdomen. I'm a right-handed surgeon and I sit on the left of the patient. I start to develop the left retrorectus space. For this, I use an optic port. I penetrate the left rectus muscle, which is here. You can see here the posterior rectus sheath, linea semilunaris on the left side, and the neurovascular bundles. I place my second and third ports under direct vision, and I start to cross over the midline, cutting the medial aspect of the posterior rectus sheath. You can see here the fat of the falciform ligament. I dissect in front of the falciform ligament towards the contralateral retrorectus space. It's very important to identify the posterior rectus sheath on the contralateral part, to place our incision laterally to the linea alba. In this way, we can protect the integrity of linea alba, and we will obtain this anatomy. You can see here the left rectus muscle, linea alba is here, right rectus muscle. At this moment, I place another port here under the right costal margin, and I change my position, continuing my dissection, my retromuscular dissection from cranial to caudal, cutting the medial aspects of the posterior rectus sheath, which become the edges of the defect. You can see here the hernia neck, the volcano sign. I start to dissect and reduce the hernia, and the next step is measurement of the defect. If the defect is too large to be closed, or if the width of the defect closely approximates or exceeds 2 times rectus width, TAR is needed. To perform a TAR, usually I start on the right side. This is the right posterior rectus sheath. And the first step is to identify the neurovascular bundles, because I have to protect them. I place my TAR cut line medially to the nerves. I start to cut the posterior lamella of the internal oblique muscle and then the transversus abdominis. You can see here the cuttage of the transversus abdominis, and I extend as laterally as possible my retromuscular dissection, and of course as cranially as I need, depending on hernia location. It's very important to keep in your mind that the transversus abdominis and the diaphragm are situated on the same anatomical layer, and they are separated by a thin fatty tissue. This yellow line is a very constant landmark which separates the transversus abdominis by the diaphragm. To perform TAR on the left, I place 2 more ports medially to the semilunaris line on the right side, and usually, because I'm a right-handed surgeon, I prefer to perform TAR from bottom to top, respecting the same steps as I presented already. Next is closure of the defect. I start with the posterior layer. It's very important to avoid any tension in the suture line. Then I restore the integrity of linea alba. Always I hang with my needle the peritoneal sac to avoid dead spaces and postoperative seroma formation. And in the end, I place a mesh, a large macroporous polypropylene mesh without fixation and usually without drains. If the hernia is located in the lower part, in the upper part of the abdomen, I sit on the right of the patient and I start developing the right retrorectus space. I place my ports under direct vision also medially to the semilunaris line at level of linea arcuata, protecting the inferior epigastric pedicle. Then I dissect the fat of the umbilical ligament to cross over the midline below the umbilicus. You can see here the umbilical ligament on the floor, right rectus muscle, linea alba, left rectus muscle. At this moment, I place another port on the left lower quadrant for the scope, and I change my position to dissect from caudal to cranial on the same way as I presented already. About complications, of course, I had a couple of complications. Here you can see a small bowel obstruction. The patient developed a small bowel obstruction on the following day from the surgery. I reduced the hernia and I My solution was to change direction of my suture line to decrease the tension in the suture line in the posterior layer. If it is not enough, TAR is needed. A retromuscular hematoma. This patient developed a retromuscular hematoma after 2 weeks from the surgery. She was under anticoagulant therapy because of cardiovascular disease. In this situation, I evacuated the hematoma and I placed a drain. A recurrence. A recurrence occurred after 1 year from the surgery. Cranial to the superior edge of the mesh, you can see here. For sure, it was a small, unobserved injury of the linea alba when I crossed over. So it's very important to identify and to protect the integrity of linea alba. You can see here a couple aspects pre and postoperatively, cosmetic and functional aspects. All my patients are monitored, just 2 of them were lost of follow-up. My experience counts around 180 cases, no chronic pain reported until now, 1 recurrence, and the mean of the hospitalization is 1 day. About complications already discussed. And in conclusion, I'd like to say that combining the advantages of rib stop-up procedure with the advantages of MIS, we get the MIS retromuscular approach, which can become the new gold standard. In the end, let me invite you in Bucharest in the middle of October for Romanian Hernia Days conference. Thank you so much.
Thank you, Victor, for always a wonderful presentation. We'll save the questions until the end, and let's keep moving with our schedule. Our next speaker is a pleasure to present Professor Philip Muisams. He'll talk will be, will robotic surgery offer the final solution to most of the cases? Let's see what Professor Muisams has to tell us this time. Philip, please proceed.
Hello, thank you for the floor and thank you for the invitation. As the last speaker of this exciting day, I think we're living a new normal, as most of us. So the title, will robotic surgery offer the final solution to most of the cases? I would like to add that for minimal invasive surgery in ventral hernia repair, since that's the topic of this talk. I do have some disclosures. I'm a proctor for Intuitive.
Philip, do you mind sharing your screen with us so we can see your presentation?
Sorry.
We're going to do a few questions since Professor Muisams, he dropped off the connection, but he'll be on soon, I assume. We have a question here from Andrew DeBox. It says, question, umbilical hernia IPON, patient presents years later with acute cholecystitis. Is there a chance of having a problem with the intra-abdominal mesh? So you had a patient that had an umbilical hernia, did an IPON, presented with acute cholecystitis. Can that mesh get infected, say, a year later? Salva, what do you think?
Well, I haven't had any problem with those cases. I have to reoperate several cases. I have to do esophageal cancer, colorectal procedure, a very bad cholecystectomy, and I've done the cases with no problem. I have done the cases by laparoscopy with no problem. I wonder if you have to do a case with acute cholecystitis or acute diverticulitis, in which you have to approach the abdomen by open approach. I will worry about previous IPON, like the one with the gore mesh, with the PTF mesh, with tuckers, but with the new techniques, I wouldn't worry so much. So with the new IPON, I really feel comfortable, because you are not going to find this terrible tucker in which you have tears on your gloves and you have the contamination of the mesh. This will be a mesh, a polypropylene mesh, there as a standard mesh in another layer of the abdominal wall.
Okay. I think Professor Muisums is back, so let's give Philip, you ready?
Yeah, but I have to share first.
All right, perfect. Thank you for getting back.
I'm so sorry. I was going to congratulate everybody that they did such a terrific job and everything went fluent, and then this happens.
All right, we can see you perfectly, so proceed.
I just want to start. Okay, sorry for that. So, topic of my talk, will robotic surgery offer the final solution for most of the cases? I've added the topic of the session, actually, for minimal invasive surgery in ventral hernia repair. These are my disclosures. I'm a proctor for Intuitive, and I do quite some research for several mesh companies and with research grants. So most of the cases, of course, we know that ventral hernia is very heterogeneous, and that's one of the problems. Of course, if you say most of the hernias, the ranges of ventral hernia ranges from the small umbilical hernia you see on top there to the more complex wide hernias and some hernias in delicate positions like suprapubic. That's why it's important, I think, and that's been stressed before, that it's to distinguish the primary ventral hernias and the classification of the hernias, trying to stratify a little bit the type of hernias and the approach we will have. This was published almost 10 years ago now, and the discriminator between small and medium was made at 2 centimeters at that time. You might be aware that the European Hernia Society, together with the American Hernia Society, published very recently a paper in the British Journal of Surgery on the guidelines of the treatment of umbilical and epigastric hernias. And interesting is to see that they changed a little bit that cutoff value from 2 to 1. When you see the defect size from 0 to 1, they say that you can still do that with without a mesh, a suture repair, or an open repair with a small mesh, and they recommended 2 centimeter overlap. Then the next group is between 1 and 4 centimeters, where they leave open the option of an open mesh repair and a laparoscopic repair. Interesting to see in the setting of this session is that in this this flow chart, the intraperitoneal option is no longer there. So they actually mention preperitoneal and retromuscular. Anything above 4 centimeters goes to be treated as an incisional hernia. Incisional hernia also has this classification. We've seen it before. It's based on the localization of the hernia, distinguishing medial and lateral hernias. And also, when it comes to the size of the incisional hernia, it's been clear also previously from the Chevrel classification that the width of the hernia, certainly for midline hernias, is the most important determinator of probably the difficulty of repair and might tailor our technique. So there's a distinction there. So if we come to, let's say, most of the cases, like how does it work? When you go to the defect width and you go 2 centimeters and you build it up to above 10 centimeters, let's say 5 years ago, this was my MIS zone, like I call it. This is the zone where I would preferably do a minimal invasive approach. At that time, being in an IPOM, and 5 years ago it would have been IPOM plus, 10 years ago, classical standard IPOM. Below 2 centimeters would, in my practice, be too small to be treated with a large mesh and a large operation, and above, let's say 7-8 centimeters, too big to treat laparoscopically. So this is what I did at that time, about 5 years ago. For primary ventral hernias, the majority, 60%, were open. For incisional hernia, it's almost 50-50%. So what did I do at that time before the smaller hernias? I did either primary closure or we placed these small patches. But through experience, we actually found that these patches is something that we're not that fond of anymore, and we don't like to place them anymore, because I think they do have at some patients serious adverse events, and also recurrence rates are higher than we would accept, I think, for these small hernias. Above 7-8 centimeters, we would do an open approach. So having stopped these small patches, actually, I've changed my cutoff line to about 1 centimeter, which is very much in line with what is now coming from these guidelines. Still do primary suture repair below 1 centimeter, but above, it would come into my MIS zone. So this is the MIS zone that is enlarging in the lower part. So in this MIS zone, you can do an open repair or laparoscopic. I was mainly laparoscopic surgeon, and at that time, it would have been, like I said, it would have been standard IPOM changing to an IPOM plus, and open repair usually for me would be a retromuscular repair. When we look at the data that was out there, this paper is getting a little bit old, and it's comparing laparoscopic and open repair. Most of the papers in there would be standard laparoscopic IPOM repair, and most of the open papers would have been retromuscular. So an open ventral hernia repair, one of the takeaways for me is that you need a good knowledge of anatomy to do good reef stopper, and it's not as easy as it seems. The overlap of the mesh is important, certainly cranial and caudal, to do good repair and a durable repair. And most often this is done extraperitoneal. Laparoscopic, I think it's easier to perform. The anatomy knowledge of the abdomen wall is a little bit less important, and it was most often done intraperitoneal. So what did they find in this Cochrane review? You had less wound effects, it's been alluded to by Salvador, a quicker revalidation, but it was more expensive because of the mesh type and the tackers, and the need for penetrating fixation was related to some postoperative pain, and also the fact that you have for the rest of the life of the patient intraperitoneal mesh was some concern. So where does the robot come in to that? I think you have several advantages of the robotic platform. You have the enhanced visualization, the wristed instruments, surgeon's ergonomics, surgeon's independence, you're in control of your own camera, and the immersive effect of the console. The question for us surgeons is, how do we translate these technological advantages into better patient care? Because that's ultimately what we want to do. I think, and of course, there's not enough data there to repeat the Cochrane review at this moment on it, but I would expect from my experience that indeed, because it's MIS, you have the less wound infections, and even compared to IPOM, quicker revalidation. The cost of the robotic instruments comes in, of course, but the cost of the mesh, if you're going for an extraperitoneal repair, is taken down, and also you don't need tackers. So this is an evolution in my practice, where you see that open surgery has decreased like significantly over the years, and also for incisional hernia. So both the primary and incisional hernias. So where I put my mesh when it's M2, M3, M4, I like to go retromuscular. This can be transabdominal, or recently also starting to do ETAP approach. If you go lateral or cranial or caudal isolated hernias, you go preperitoneal and sometimes intraperitoneal mesh. But intraperitoneal really has become the minority of my operations. You see the increase in retromuscular or retrorectus repair, and the decrease of intraperitoneal mesh repair in my practice. So what about too big? can we improve on that? And this is indeed, I think, the area where the robot is going to make a difference for our patients. These large hernias, can you do them laparoscopically? Yes, in the beginning we did, but the functional result wasn't that good. So together with me, many changed from laparoscopy to open surgery. The TAR came on, posterior component separation. It's actually these patients that we are now taking back to minimal invasive surgery with the robotic TAR. Of course, in America, they're up front of us on the experience on the robotic platform for hernia repair. But really, my experience is the same as in this paper, a significant reduced length of stay for these more difficult hernias. So indeed, also doing less and less open surgery for these big cases and increasing my MIS zone. So ultimately, if you look at this screen, you could say it's indeed, like in the title, most of the cases. Not all of them, and of course there are some issues like fistula and other things, infection, loss of domain that have to be discussed. But I think indeed that we can, because of the robotic platform, certainly for the wider hernias, we are able to do them minimal invasive now. So if you want to learn, there's another initiative of the European Hernia Society. We're ambitious. We're hoping that in September we will be able to organize this course. It's a discovery course. Applications are open now, and like Victor, I'm also still convinced I'm going to hold a meeting here in November, and with some good wins and good luck, that you will be able to join us there. Thank you, and sorry for the mix-up. I pushed the wrong button.
Very nice, Philip, as usual. First of all, congratulations to all the speakers for a high level of your presentations. We have a few questions. Wolfgang is with us, also the moderator. I'm going to start asking a few of them that we have from the audience that we have around the world. Whoever wants to take it. This is from Abdullah Al-Katani. Is there a hernia defect size that we shouldn't do IPOM plus? Victor, you're an expert on retromuscular and component separations, etc. If there's a size that you say I'm not doing IPOM plus?
Well, before I started to repair the ventral hernias by ETEP and ETEP TAR, I was a fan of lap IPOM, and in this situation with a very large defect, I start doing an endoscopic anterior component separation to close the defect and then to place an IPOM. So probably it's a relative contraindication, the width of the defect.
Let's give these guys a number. You say one number pops in your head saying, this may go more than just, I won't do this IPOM plus, I'm going to have to do a component. What would you say an average number in your mind?
Well, not too many.
Eduardo, we when we start doing the IPOM plus and closing the defect, we start, as I show you, following our patient, and those from 5 to 10, we have a recurrence rate around 7%, and they were bulging, but it was a reasonable recurrence rate. But when we move into all the cases that we follow, over 10 centimeter width, I mean, the rate of recurrence was so high. So we stopped doing any cases over 10 centimeter width when you measure in the CT scan, not the hernia defect, the distance between the rectus. In those cases, we decide to stop doing the IPOM plus and closing the defect because the rate of recurrence was so high. So in those cases, we move in a laparoscopic component separation.
Salva, since I have you there, there's a question from Mukun Ketan. How much medialization of the rectus can you get by LIRA?
Mobilization medially?
Yes.
We maintain the same rate. Since we learned that 10 was too much, then what we do is when we have cases with more than 10 centimeter, sometimes, so we've done some cases with 8, 10 centimeter width, we move directly into a component separation. We don't even try.
Okay. There's a question.
Okay, there is another question for Salva from Portugal, Ricardo Soto. He asks, the LIRA is an interesting technique to address the defect process, but it does not seem to reapproximate the rectus muscles towards the midline. Could you comment on this, please? Best regards from Portugal.
Yeah, I mean, it does. When you open the flap and you bring it to the middle line, since you have this release incision, the muscle comes to the middle line. So I could have a big flap and maybe go over 10 centimeters, but that's the reason why I stop at that moment and I don't try. Because if you do over 10, maybe you can have a flap or posterior fascia, but you are not reapproximating the rectum muscle in the linea alba. And that's the reason why I stop at that limit. Sometimes even less, 9, I've done some TAR with 8, but I think 10 is the limit that I would say, because you don't get the muscle together, even that you release the tension.
Okay.
There's a question here for Victor. Says, what do you do if you're dissecting the retrorectal space, but in the crossover you enter into the onlay area? This is from Osvaldo Alejandro Martinez. What do you do if you're dissecting the retrorectal space, when you're crossing over, you enter into the onlay area?
Well, this is a mistake, a bad technique. So it's a wrong plane. It's not a proper technique. So a correct technique, doing a correct technique never will be on the onlay plane.
So let me ask you a question, Victor. If you're gonna give him some advice, what will you enter? Do you think it's easier to enter towards the falciform ligament, or they should enter towards the hypogastric area, or what will you do in these cases? Give him some advice.
So always you should start on the opposite part of the abdomen to the hernia location, in the virgin part of the abdominal wall. If the hernia is located inferior, you should start to cross over in front of the falciform ligament, because it's a virgin part, no scar, and it's easy to dissect a virgin layers of the abdominal wall. It's not easier to cross over the midline from below or from above. It's the same.
Another question to Salva from Barbara East. She asked, when you fix the mesh with absorbable method, doesn't it lead in the long term in mesh slipping away? We were told in one of the previous sessions that polypropylene mesh does not integrate into the peritoneum as it's of mesothelious origin. What is your comment on that, Salva?
Yeah, that's the reason why when we start setting this technique, one of the questions that the people had when we were doing IPON Plus is that the literature was saying that you have to have an overlap of 5 centimeters when doing an IPON. So then you close the defect, and the defect becomes from N to 0. So 0 means 5 one side, 5 the other side. So then we start thinking, okay, so what am I going to recommend? So we were recommending, when doing an IPON Plus, to overlap as the original size of the defect, which was wrong. So for that reason, when we start doing the LIDA, we developed how to overlap the defect, and it was easy. When you open the rectum muscle, you bring it, the lateral side of the rectum muscle stay in place a little bit, or they come a little bit to the midline. And we decide to overlap the opening just 2 centimeters. So the amount of polypropylene in contact with pure peritoneum will be only 2 centimeters. So the rectum polypropylene will mimic the rectum muscle and will integrate properly in the abdomen of the patient. So those 2 centimeters will have like cells and neurovascular coming from the muscle. So I'm not worrying about these just tiny 2 centimeters of polypropylene against pure peritoneum. So I'm not worried about that.
Okay, there is another question for Victor by Abdullah Al-Katani. He says, nice talk, Victor. first complicated case, the second surgery you showed us, you closed the peritoneum defect only, question mark. The old question whether to close the posterior rectus sheath or not. Your comment on that, Victor?
Yeah. The posterior layer is not a resistant layer. It's just a barrier between the mesh and the viscera. So it's not necessary to suture the posterior rectus sheaths. We can preserve the peritoneum bridge between the both retrorectus sheaths. But on that case, I closed under not too high tension, but it was a tension. It was quite easily to reapproximate the edges of the defect in the posterior layer. But you saw what happened. On the following day, a rupture occurred in the posterior layer, and that was the complication. So that because of that, I mentioned is very, very important to avoid any tension when you close the posterior layer.
And another question to Victor. What do you do if you are dissecting the retrorectus space, but in the crossover, you enter to the onlay area on the opposite area? What do you do?
That one he answered already, Wolfgang. He answered that one. Let's move into Philip. Says, is robotic reimbursed in Belgium and how? And there's one more question, if you can answer both, is how do you recommend to attach the mesh in the Robotar? So if you're reimbursed, and how do you attach the mesh in the Robotar?
So there's no specific reimbursement in Belgium for robotic technique. We do have for laparoscopic technique, we have a material forfait. So which would be the same if you do a laparoscopic IPOM or a laparoscopic groin hernia repair, or you do it robot assisted, that would be the same money you get there. So we do get some money for the material, but that's not more because it's the robot. The thing is that for groin hernia, obviously you're paying more, but if you do robotic ventral hernia repair with an extra peritoneal mesh, you save money because you use a cheaper mesh and you don't use stackers, and that money equals out more or less with the robotic instrument. Fixation in Robotar, so the component separation technique, I do not fix. We use quite big meshes, which is like 30 centimeters in width, 30 centimeters, 40 centimeters in length, and we just place them like Stoppa would do that for also in his open approach. No fixation.
Let me ask one question to Sam, and I think to close this because we're already on time. Sam, you think we're gonna get to a point that we speak the same language across the research papers? You think we can get to that point, or you think we're still gonna go all over the place?
Am I unmuted? Yeah. Good question. Thank you very much. The only thing you can do in order to improve research and to create a standardized language is to try and produce good research yourself and produce articles that people enjoy reading, that propagate throughout the literature, and you can just do your best. I think I would love it if it was endorsed by other surgical hernia societies. And indeed, if other specialties wanted to use it, like radiologists who are interpreting CT scans of ventral hernias and looking at where mesh has been placed in previous hernia repairs, that would be fantastic if it propagated into other specialties as well. But you can just do your best. And I think in the 21st century, where this area of surgical science is taking off hugely, the number of papers published in abdominal wall reconstruction every year is growing at a hell of a rate. So we can just do our best and try and produce good science.
Well, I'd like to thank Salva and Hernia U. Wolfgang, do you like to close the session?
No, I think we have another 30 minutes left. I was just informed by Jen that we have another 30 minutes left. So there are some more questions we could ask. There was one interesting question from Andrew DeBow. He asks Philip, in the very large hernias, do you offer sometimes combined abdominoplasty? And if so, does this changes your strategy using the robot, for example? How is your concept on that?
Yes, for sure. There is a patient selection. So certainly, for example, patients that had weight loss surgery and lost a lot of weight and have a very large panniculus, these are patients, if they have a concomitant incisional hernia or ventral hernia to repair, we do them open in combination with the plastic surgeons. Same with postpartum patients. If they have a lot of excess skin, we don't use the robot for those. We do them open because they lift large skin flaps, and it's quite easy to do an open retromuscular repair. But I would still do retromuscular repair. So basically, I'm doing the same technique, but I would do that open. In patients with less extensive excess skin, I often tell them, let's wait, and after surgery, if it's necessary, we can you can come back for an excision of excess skin. But that has not happened in my experience. They come from a large bulge to a flat abdomen, and the skin retracts to a level that usually patients are comfortable with. And they often are not young patients, so they're glad to have a flat belly, although their skin might not be that good looking at the moment. But we do have a patient selection. I do quite sometimes open surgeries as well for these patients, together with plastic surgery.
Excellent. There's a question from Masen Al-Masur. Dr. Radu, can you elaborate on your algorithm between Rives, Topa, and TAR?
Excuse me?
He wants to see if you can give him an algorithm. So when you choose Rives, Topa versus TAR.
Okay, so one of the big advantage of the retromuscular approach, doesn't matter if it is ETEP or EMILOS, is that you can adapt during the surgery to perform or not a TAR. For example, there are many situations when the defect is not too large and it's impossible to approximate the edges of the defect, to close the defect, because there are a lot of variables in our equation. It's about the rigidity of the abdominal wall, for example. Sometimes it's impossible to close the defect. And you can adapt during the surgery when you extend laterally to the semilunaris line your dissection, your retromuscular dissection. Sometimes it's enough to perform a hemitar, sometimes it's not. So I think another big advantage of the retromuscular approach is that we can adapt during the surgery to the situation, to the defect.
You have another question, Wolfgang?
Yeah, there's a question from Miguel Magdaleno Garcia for Victor. Which is the best size for ETEP ventral repair for wide and longer? Which is the best size for ETEP ventral hernia repair, Victor?
There is no recommendation regarding the size. You can fix all of the ventral hernias, doesn't matter the defect. Of course, there are relative contraindication in very large defect and loss of domain, as I mentioned. For sure, for starting, it's better to start with primary ventral hernias, not too large, of course.
Let me see.
There's one for Salva. What is the advantage of ETEP versus LIRA?
Well, every time I talk and I have another presentation in which at the end I make like the difference between one technique and the other and what is the advantage of one or the other. I would say that a LIRA is more reproducible than the ETEP. This is the first thing, because you can you have the difficulties of access of organize yourself with the anatomy with the ETEP access. So that's the reason why I mentioned that is more reproducible. The second thing is I do the supplay, a retromuscular approach in primary hernias because in primary hernia, you can cross over to the other side and you have less possibility of having a tear of the peritoneum that you have to close. And at the end, you have doubts if the polypropylene mesh was going to be in contact with the bowel. So, and that's the reason why I like ETEP and the retromuscular approach for primary hernia, but I don't like for the incisional hernia, because incisional hernia, the scar tissue, sometimes, and I've seen it in some live surgeries, you can open the sac or open or tear in the peritoneum and have a problem. So that's the second reason. I like the LIDA because you don't have that problem. And the third thing that even like yesterday, I did, for example, a LIDA in a patient after a classic IPON that I was performing in another center, and the classic IPON moved the mesh to one side, and it was a meschoma in one side of the abdomen. So I removed the mesh, and after removing the mesh, I make another, I make a LIDA, I perform a LIDA. I think like performing an ETEP or this access with patient with a previous mesh with the tackers attached to the fascia and the muscle, it will be kind of difficult. And even I perform the LIDA technique in patient with a previous with a previous repair with a positioning a mesh in a retromuscular space. So what I mean is at the end, that it is more reproducible and there are more indications for the LIDA compared with the ETEP. And that's the reason why I consider, I'm not against ETEP. I'm not against the Milos. I'm not against about retromuscular access, minimal invasive retromuscular access, but I consider that this is basically the advantage. I don't know if Victor agree with the reasons what I mentioned.
Well, I would like to highlight two aspects. One, you are totally right. It's a quite challenging technique, and it's not easily to reproduce it. This is the first. The second, I would like to precise that the ETEP is not an extraperitoneal surgery. Just the access is the extraperitoneal. For example, fixing an incisional hernia, and most of the time we open the sac and continue our dissection intraperitoneally to perform adhesiolysis before to close the posterior layer. So the ETEP is just an extraperitoneal access in incisional hernias specifically.
There's a question here for Salvador again. What are your thoughts on absorbable versus permanent suture and mesh width overlap with and without LIRA? It's from David Lurie. David, nice to talk to you.
My first option will be to use a absorbable fixation device. But on the other side, I will say that I have no commercial interest, but it's true that all the absorbable fixation devices are not the same. Basically, there are three in the market: Absorbatap, Optifix, and SecuriStrap. But the strength of fixation of each of them is totally different. Not only the strength of fixation, the applier, because if you have to move it a little bit and bend it a little bit, the strength of the fixation will be totally different with the fixation device in the market. So this is one of the things. Whenever you are going to decide, I'm going to fix with absorbable fixation device, just take into consideration that not all are the same. When am I using permanent tackers? I'm using it in for example, the case that I did yesterday, the LIDA. The patient has a previous recurrent or a previous laparoscopy. There was kind of the tissue wasn't in good conditions. I have to. The width was 8 centimeters. Was a large hernia. So in that case, yesterday I decided to use permanent tacker. But I would say that now today, to do a LIDA, 20% of my cases is with permanent tacker, and 80% I use absorbable fixation device.
Salva, since you're there, Villalobos Rafael wants to ask you, do you use cyanoacrylate or fibrin glue to fixate the mesh in IPOMs?
Well, in IPOM, what I do is we conducted a study a long time ago in which we knew that that original conventional IPON in which we were placing tackers every 1 centimeter, that was the beginning, in 2 rows, that was not necessary. So we start opening the gap among the tackers, and we move from 1 to 3, even to 4 centimeter, and we place each fixation device like every 3 centimeter. So what we decided to do at that moment was, let's say, I was a little bit afraid of having the bowel going through between the mesh and the abdomen, and we decided to seal the gap among these tackers with fibrin glue, because it's spray, not because fibrin glue. It's because cyanoculate, at that moment there was no cyanoculate that could spray. So I'm using that. What I'm doing is sealing the space. Is sealing. It's not the question of gluing, because I don't believe that with this technique there is no enough evidence to say I'm going to glue in an IPON. I glue when I do the retromuscular approach, because it's another space and it works totally different. And I use glue in that space, but not intraabdominally. Intraabdominally, I use it to seal the space among the tackers.
There is another question for you concerning if you planning a LIRA repair and you enter the abdominal cavity and you see loads and loads of adhesions. What do? You proceed with an extensive adhesiolysis, or are you considering a minimal invasive extraperitoneal approach?
So a lot of lobar adhesions mean a lot of time. So I'm going to do the dissection. This is one of the things also about LIRA and ETEP, and I would like to comment on that of Victor and Philippe, what they think. Because if you do a pure retromuscular approach and there is a lot of adhesions, and while you're going to the other side, you open the peritoneum or the sac and you're not aware of the content, you can have a bowel injury. And this is what I'm afraid also about these techniques. By LIRA, you control your adhesions. You will learn in the last year how to avoid a bowel injury. What I'm afraid of those people going, and in fact, there are some people who recommend to do a retromuscular approach, but before to do the retromuscular approach, the pure retromuscular approach, to do an intra-abdominal check of the adhesions and do the adhesiolysis from inside.
Yeah.
So at the end, if you're doing, if you find a lot of adhesions, spend a lot of time in the proper way to do the adhesiolysis.
Yeah, that's a comment from my part. We didn't talk about Milos and E-Milos in this session. This is one of the advantages of Milos. If you access by the midline in an incisional hernia after a midline incisional hernia, the advantage of the Milos and E-Milos approach is that you start with the hernia sac, and this allows you to do the dissection more safely. You don't have to do the crossover from one side to the other. You dissect the hernia sac and go to the lateral part. This is much safer. Even when you start with a little tiny incision, you are able to use your fingers, palpation. You can open the peritoneum and look inside the abdominal cavity. It gives you more safety in my point of view, in my experience. This has to be considered. Victor, what do you think? Are you sometimes considering E-Milos or Milos approach in incisionals?
Well, I don't have any experience in this approach. I saw your surgeries. I think the principle is the same. I'm quite well trained in ETEP, and I've never quit it. But I think the principle is very similar.
I would like to comment on, because Salvador asked to, the transabdominal approach of a retromuscular repair, lateral approach, adhesiolysis is the first thing I do. I never start my retromuscular dissection before I've done an adhesiolysis of the anterior abdominal wall. That's part of the technique for me. Of course, with ETAP, that's a bit different. That is probably one of the major differences between a transabdominal approach and a purely extraperitoneal approach. But adhesiolisis is really a big. It's the first step of this operation for me every time.
There's another question for Salva. Which type of mesh do you use for Lyra?
Well, I use polypropylene-based mesh covered by I use different meshes depending on the ability in the hospital, because I work in 2 different hospitals. What I can say that I was a fan at the beginning of my going through laparoscopic approach and LIDA. I'm sorry, an IPON. I started using PTF because at that moment, PTF was the only mesh that you can trim, because the old meshes of polypropylene with PTF, you trim them, you expose the polypropylene, and I didn't feel comfortable with that. For that reason, when I moved from pure PTF to the standard mesh that we use now, that is the polypropylene-based technique, polypropylene-based meshes with a cover, you can trim them because the edges, the substance that cover it, it will cover the polypropylene and will not be exposed. And that's the reason why I changed. I still use PTF for 2 cases. One is the parastomal hernia. I like to use in parastomal hernia by laparoscopy the PTF, the pure PTF, because I like to have PTF in contact with the bowel better than polypropylene. And the other cases are the large neuromuscular denervation, lateral neuromuscular denervation. In those cases, I don't close the defect, I don't plicate the defect. And in those cases, what I do is I dissect the tissues, I go laterally, and I place the mesh laterally, I release tension, and I fix the mesh to the rectal muscle, creating a new wall. And I believe that the strength of the PTF in that condition, it will work better. And I have a good result with that. And that's the only indication for me today for the pure PTF mesh, and the rest of them polypropylene-based mesh.
Okay.
Here's one interesting question for all of the speakers. Many hernia patients have obesity. Will you recommend bariatric surgery before MIS ventral hernia procedures? What is your opinion on that?
For me,
bariatric
I think
surgery before MIS. Salva, you are also doing bariatric surgery. What is your comment on that?
Well, bariatric and ventral hernia is a big topic. I'm doing a lot of bariatric also in my center. We only do symptomatic hernias or patients that have, we perform a CT scan. If the patient have bowel incarcerated, then we perform the 2 cases at the same time. But only symptomatic hernia. If it's not a symptomatic hernia, we perform a bariatric procedure, and then in a second stage, we decide to go for the ventral hernia. And most of the cases, if we go in the second stage, we will do the dermal lipectomy with the plastic surgeon together with the open approach. So, but in those limited, small number of cases in which we have a symptomatic incisional or ventral hernia, in those cases, I perform the bariatric procedure and a laparoscopic approach in the same at the same time. And there is literature who support that support that is no problem to perform a bariatric procedure and placing a mesh intra-abdominally, even with a sleeve gastrectomy or gastric bypass.
so. For me, when we have a very obese patient, that would fall in the category where they could get bariatric surgery. We do recommend that for major surgery. If it's like an incisional hernia that's going to need a reef stopper or a TAR. For just an umbilical hernia, you can recommend them to lose weight, but if it's just a primary umbilical hernia, it's symptomatic. You don't want to treat it. You don't, and if a patient doesn't want bariatric surgery, you could still go for it. But weight loss is one of the things that you want to strive for, and bariatric consultation might be part of it.
At our centre, we've got a pretty good medical weight loss program. So patients get sent for that. Getting bariatric surgery in the UK can be quite difficult to get funding. And we've got some good successes with medical weight loss. We try and get the BMI below 35.
Well, weight loss is a very important point operatively. If it is possible to refer the patient to bariatric surgery, I do, but often, especially in incisional ventral hernias, it's not possible, and I perform primarily a hernia fixation of the incisional hernia.
Another question to Victor by Manzen Al-Mansour. When you do a knee tap, how do you avoid bowel injury while attacking the volcano, while opening the sac?
Yeah, it's a very good question.
You do it with a cautery hook. What is your strategy?
It's a very good question, but you know, in most of the situation, you can find at least a small transparent area, peritoneal area, when you can penetrate into the peritoneal cavity to have a look inside. Then, if the adhesions come across, you can perform adhesiolysis and do your dissection in safe. The risk to injure the bowel, I consider the risk to injure the bowel is not higher than in lap IPOM.
Do you enter the sac, Victor?
Yes, of course, ideally is to stay outside of the abdominal cavity as long as you can. But often in incisional hernias, because the tissues are scarred, you encounter scar, you will penetrate into the abdominal cavity. And if adhesions come across, of course, you perform adhesiolysis first to continue dissection.
Excellent. There's some people asking, since we done this online meeting, this is something that's going to keep growing. This is to all the panelists. So do you think this is just going to be until COVID it's gone, or what's going to happen next year?
I hope not. I quite like going on holiday. I'd love to go to New York, and, but it's very convenient, isn't it? I'm really enjoying it, and to get experts into your living room is fantastic. So maybe it'll be both. Maybe the speakers will come to people's rooms worldwide, and the conference will be available for the people who want to travel. I don't know, but a hybrid approach might be a good idea.
From my side, I think we've seen so many meetings I followed, so many webinars. The first Congress that is going to open, I'm going to fly there and sit in an auditorium. And I think many surgeons will feel like that. It's part of our culture. And of course, we can do a lot of things. Do you really have to fly to Asia or Australia to attend a meeting? I don't think so, unless you're giving a lecture. But yeah, I don't know. Maybe indeed a combination of both. The good thing about online things is that it's there, and this is being recorded, and it will be there, probably available on the different platforms for people to watch afterwards. And we did that 2 years ago with the Robotic Congress, which was posted on Facebook, and we have still a lot of people regularly watching that, and some of these presentations, they have 30,000 views, things like that. So that's a good thing, that it keeps being available for people that could not attend the meeting itself. But hybrid is surely good for me, and I wanna fly as soon as I can.
What is true is that the good thing about let's say these this will consider the closing remark that was after this session, that it was like only 3 minutes left, but we will make this as a closing remarks. But what is true is today we have 1,800 registration, a peak of 1,200 people at the same time connected, and never below 800 people. I see comments from all over the world, Latin America, Asia, Myanmar, Iraq, Iran, and I think we're reaching people that they don't have the possibility of flying, and even some hospital in Spain, because of the limited number of the member of the unit, they cannot travel to congresses. So we're reaching so many people, and this is the good thing. But on the other hand, it's true that after a session like this, I'm pretty sure that I will have a beer with Wolfgang or with Victor, Sam, Eduardo, and Philippe, and talk about, and this is the way to create science, because we talk about the future, what we could do. Maybe we start doing a multi-center study, or having an idea to do like the HICAP that maybe it was raised in a congress with a coffee with Philippe, or things like that. And so I consider that both we have to combine in the future both way of going for congresses. So the numbers are impressive today, and I thank everybody who is connected. It's impressive to see the number, but let's see the future how it goes. But the most important thing is that at least we have the chance to travel, and if we have the chance, means that this is over, because we are tired of this virus.
So I have to say, I miss you all. I miss the congresses. I miss meeting you and having the personal contact, drinking, attending real surgery. But this experience today is fantastic. And this session about minimal invasive ventral hernia repair was incredible. We learned a lot about anatomy. Samuel gave us a brilliant talk about the planes and how we should describe the planes in the right way in the future. Then, of course, Salva told us that Lab IPOM is by far not dead. It still will be there. The Lyra technique is a very good approach. Of course, robotics is there. Philip has brought the robot from the US over to Europe, and I'm very sure that the robot will be the future of ventral hernia repair will be with a robot. I'm absolutely convinced. And of course, also Victor's excellent talk about his ETAP experience. It's incredible. I know that ETAP is the brother and sister of Milos and E-Milos, and we're doing more or same the same thing, and the results are so convincing. And I must say I learned a lot, and I would like to thank the speakers. And now I would like to give over to my co-chair Eduardo for the final words. Eduardo.
Thank you for the opportunity. It's been great to be with old friends and listen to wonderful lectures. And this is a new way to connect. I agree with everybody. It'll be a mix with all the things going on, but let's keep working towards our patient and getting better with experience and knowledge. Thank you so much for the opportunity. And I think, Salva, we're going to close the session at this point, if you agree.
Sure.
All right. Thank you so much for your time.
Thank you.
Wonderful talks.
Thank you.
Thank you, everybody, for being here. And tomorrow we will continue. Tomorrow morning at 10:30 we start the sessions.
Okay. See you tomorrow.
Bye-bye. Bye-bye.
Bye. Bye.